طبعا عندنا الآن لسه باقي 4 دقائق، فهذا الجدول طبعا حق اليوم إن شاء الله. We'll finish by 12 o'clock hopefully. Okay. Our lecture today, I'm going to talk about multiple trauma in children. I hope some of you are emergency physician who did ATLS. Any one of you did ATLS, nursing or physician? Yes, good. There is some nurses, they did, okay, Carol and Bedur. Very nice, excellent. طيب, I think I will make it very easy, very simple, okay, for the nurses and for physician. You know, the idea behind these life support courses, it make you well organized, not confused. Because, you know, during accident, because of, or during arrest, or during any like life-threatening event coming to the emergency, you are like confused. And most of the people confused. You see nurses coming from everywhere, physician coming, RTs, everyone try to help. But as you are the team leader there, okay, you have to organize your team and your thought, very important, okay? This will make it easy to manage this patient. There is nothing to be declared. And I will start with a simple case. It's not a simple case, but we will try to make it simple, okay? And if you have any questions, and we will make it like interactive, if you don't mind. This is a 12-year-old boy who was involved in a high-speed motor vehicle crash. On arrival to the emergency, he was unconscious with a bag valve mask ventilation provided by the EMS paramedics. His initial vital signs were pulse rate 150, blood pressure 70/40, his respiratory rate 30 per minute with shallow breathing, his temperature 37.2, his oxygen saturation around 85 on 100% oxygen by bag valve mask ventilation. So, what do you think? This is just for those who just came. This is a 12 years old involved in a car accident, and his vital signs, as you can see. Any comment on the vital signs? Let's make it interactive so we can finish. Is he in shock? Yes, excellent. Hypotensive. He's in shock. Okay. So this patient, and I'm presenting this case, I'm giving you the worst scenario to the emergency, and just to see how it is easy and simple to manage it if you are well organized and using the ATLS guidelines, okay? So the patient, as some of you mentioned, he's in shock. This is not going. Okay, and he has a reduced air entry to the right lung and hyperresonant. What does that mean? Reduced air entry to the right lung and hyperresonance. This is pneumothorax. Excellent. Okay, how you approach this patient? We'll follow the ATLS guidelines. Okay. A, B, C, D, excellent. Okay, so A stands for airway. It is the same, like ACLS, like in PALS, like everything. But in trauma, there is a specific precaution that we should take. Okay, for example, if we are managing the airway, we have to protect the C-spine. So there is no head tilt. Okay, be careful. bending the neck, it is very dangerous during trauma. So you have to make sure that there is no C-spine mobilization. Breathing with adequate ventilation, circulation with controlled breathing. This is very important. The disability with neurological status, you have to assess the disability, Glasgow Coma Scale, we mean. Okay, and then exposure, and it's very important to expose the whole body just to make sure there is no other trauma, extremity, distracting trauma. Okay, we have seen children come, most of the children, when they involve in a car accident, most of the time they are having mainly head injury. And head injury, sometimes they may have deformity of the lower limbs. So you have to be careful when you are dealing with, so you have to expose, but you have to make sure that they won't go into hypothermia. So we will follow ATLS guidelines, which is very important. Okay. So this patient, as we mentioned, there is a reduced air entry in the right lung with hyperresonance. So most likely, as you, some of you answer, and they said this is most likely tension pneumothorax. And how you manage it, you have to relieve it immediately as soon as possible by inserting a large bore needle, 14 to 16 catheter at the mid-clavicular line, second intercostal space. And it should be followed immediately by inserting a large bore right-sided chest tube underwater seal. So this is the first step. Of course, we have to provide oxygen to the patient. We have to connect the patient to the monitor. We have, if there is an obvious bleeding, we have to control it very well. But you have, as a team leader, you have to think systematically. So airway, breathing, circulation, but at the same time, it should work, together. We shouldn't like say, oh, there is a bleeding, I shouldn't stop the bleeding or apply pressure until I secure the airway, or I put an IV line, or just intubate the patient. No, you have to apply a pressure dressing to stop the bleeding. So we have to work together. During trauma, we have like 5 people there, including the team leader. One will take care of the airway, another will take care of the of vascular access, someone will take care of the cardiac compression if he needs a CPR, and someone will take care of the recording all the medication and events one by one. And also the last one will be the most important, the team leader who is standing at the foot of the bed or for the patient and giving instructions to his team. So it is like a teamwork. Okay. So we establish also so as we mentioned, we put an airway, jaw thrust, apply semi-rigid collar. This is very important to secure the C-spine and also relieve the tension pneumothorax, as we mentioned. Okay, so after inserting the chest tube, we have to establish now a definitive airway by intubating the trachea, because the patient is still hypoxic, he is still even with 100% oxygen, and we have to ask for help. And most of the time we are announcing code for this patient. Okay. And if you are not experienced in airway management, you have to ask for help from your colleagues or your seniors, or what, anesthesia, or sometimes RTs if they are available and they are expert in inserting the airway. Since airway in a multiple trauma, sometimes you have victims who's coming to the emergency with difficult airway, like there is no clear anatomy, there is bleeding everywhere, oral bleeding. So you may need help from specialized people like anesthesia or ENT sometimes. B, you have to, which is breathing, ensure after inserting the chest tube, there is a good oxygenation and ventilation. Okay. At the same time, we have to insert a large pore. Okay. this is what we, after we insert the large chest tube without any delay, we have to give 2 liters of normal saline. He is 12 years old, so we assume that he is around 50 kg. 50 kg, that means you have to give like 20 per kg, 1 liter. But sometimes we can give also, like if he's still hypotensive, we give another liter of normal saline or ringer lactate. I think so far we are happy with the management. So the most important, establishing the endotracheal tube after inserting the chest tube, and start IV fluid as early as possible, because the patient most likely he bled or somewhere and he's hypotensive. So we have to, and why he's hypotensive? Do you know why? His blood pressure 70/40. He is 12. What is the accepted systolic, minimal systolic blood pressure accepted normal for this patient? He's 12 years old. Those who did PALS, okay, if you remember, it is 2 by age plus 70. This is the minimal systolic blood pressure accepted. So 2 by age, his age is 12. 2, that means 2 by 12, 24, and by plus 70, that means 94. This is the accepted, yeah. It should be above 90, absolutely right. So he is, his blood pressure is 70/40. So definitely he is hypotensive. Why he is hypotensive? Like someone of you, Taha, he mentioned that because of bleeding. And this is, could be right, could be true, especially in trauma. Can hypotension, can be head injury, can cause hypotension? Question, yes or no? You know, most of the children, they have head injury mainly. Can they have hypotension? No. Excellent. No, this is true. Where is the most areas of bleeding that we should look for in a trauma victims? Chest, excellent. Abdomen, excellent. Okay. Pelvis, excellent. And the last one? Yes, big bones, okay? Like femur, okay? Because there is a femoral artery, femoral vein, and long bones, so they may lose a lot of blood. So there is 5 areas: abdomen, chest, pelvis, long bones, and the 5th is what? Outside, external bleed. Okay, so you have to look for this. So the case, let's continue now. We assess the pupil and Glasgow Coma scale. This is disability, okay? And we expose the patient and we check for site of active bleeding, skin, and musculoskeletal system. And then the secondary survey to examine the patient from head to toe, okay, to look for any signs of bleeding or any abnormality finding. Adjuncts, what's adjuncts we should do? Like blood work, okay? So we'll draw for CBC, chemistry, we call it a trauma, okay, profile, okay, blood group, and okay. NG, yes, we can consider nasogastric tube, but you have to be sure. If there is no basal skull fracture, you can put NG. If there is a basal skull fracture, it's contraindicated because the NG tube may go to the brain. Okay, and we have to reassess the patient very frequently. Okay, so after giving the boluses of 2 liters and after putting the chest tube, the patient, what happened to the patient? Okay, this is what we did. After putting the needle and put a right chest tube, there is 200 cc of blood were out coming from the right lung. So this is also there is significant bleeding there. And it stopped, and the patient was intubated and ventilated, and 2 liters of normal saline were given. So after doing all these 4 steps, the patient improved, and then he went down, deteriorate again. So his pulse rate from 150, it went down to 110. Okay, this is good. Blood pressure improved, but still 80/60. And the saturation is 90% on 80% of oxygen. Glasgow Coma Scale was 8, then there is a sluggish reactive of pupil. What will you do next? Why he is deteriorating again? This is another question to you after giving 2 boluses. You are right, we have to reassess the patient, re-examine, ABC. So the patient is deteriorating, so we go back, airway, the tube is in, everything is working, airway is okay, all right, and so what could it be? His vital signs, it showed me that he's still hypotensive. So what could it be? Not herniation, no, too early for herniation. Bleeding, excellent, Fatima, you are right. He is bleeding somewhere. So how we can test? Can we send this patient to CT to check for bleeding anywhere in the chest and the abdomen and the pelvis? No, no. Somebody say E-fast. Excellent, excellent. So the fast should be considered. Okay. And this is the initial assessment, adjuncts. You know, this is, you have to do it portable, like lateral C-spine. But if you are going to send the patient for CT, we usually do C-spine. And the most important of C-spine X-ray is the lateral one. And it is very simple to read it, just to show you, because some of you, they find difficulty in reading it. No, it is not difficult. First, you have to make sure, is it adequate? You can say, use ABC algorithm. Abbreviate A for adequacy. Is it adequate? Yes, we can see the base of the skull, and we can see here the shoulder. So you have to count 1, 2, 3, 4, 5, 6, 7 cervical spines. That means it is good. You have seen all the spines. So adequate. So this is good. B, bony. If there is any bony changes. Okay, let me see. This is the vertebral body. You can draw anterior vertebral line through the anterior surface of the anterior of the vertebral body. This is the vertebral body. You can see the arrows. I'm using it, the arrow. Okay, so this is anterior vertebral line. You can draw a line. You can see there is a straight line. It's not, and the posterior vertebral line and spinous process lines. Once you do this line, you put a line. This is a simple way to read this, the lateral X-ray. If there is a stepping out or in of the vertebral body, that means there is a fracture or there is some abnormality. Okay, through the anterior vertebral line, posterior vertebral line, and spinous process line. Also, you can see here the soft tissue. Is there any soft tissue swelling? Sometimes we can see like this one here, the oral airway, and there is some hematoma. There is bleeding somewhere, okay? And it's pressing on the airway here. So this is a simple way of reading the chest X-ray. Also, as you can see, there is a tension pneumothorax in the right side, and so we can put a chest tube. This is the pelvis. So this is the 3 main things that you should do for every trauma patient: C-spine, chest, pelvis. But if you are suspecting some, for example, femur fracture, tibia, or whatever, any part of the body there is a fracture, and you need, you can add it to the X-ray that we usually do it for every patient with a trauma, which is C-spine, chest, and pelvis. How you read the pelvis? Pelvis is very simple also. The most important fracture in the pelvis, usually it is here. This is what we call it, the superior ramus. And here, this is the inferior ramus. Both we have right and left, okay? And usually it is a very weak bones. But alhamdulillah, thanks God, whenever it has a fracture there, there is no need for surgical intervention or orthopedic intervention. Okay, so this is very important. So how you read the pelvic? You have to make sure it is good view, okay, that involving the whole pelvis you can see, and part of the femur, the head of the femur, okay, and you can make circles around. So make circle from here. This is the sacroiliac joint, as you can see. There is no problem, no spacing, no deformity. You can see the bone, for example, the sacrum is pushed in or out, and this is the iliac crest, it is in or out. And also you can just draw a line and go over the line. If there is a fracture here, you will notice it. Okay, and then go here. This is symphysis pubis. Sometimes if there is a significant bleeding here in the pelvis, you see widening of the symphysis pubis here. This is symphysis. So this is important. So then you go, make a circle. If there is any fracture here in the superior ramus or underneath the inferior ramus, it will be very clear. And continue your line. Sometimes we have the head of the femur is pushed in, okay, or there is a neck of the femur fracture. Okay, then you continue. This is the sacroiliac joint. The iliac, you can see there is a significant fracture or there is a spacing here. Okay, so this is a very easy way. If you keep practicing doing this, it will be very easy to read the pelvis. So we gave the patient 2 boluses of normal saline and hemodynamically stabilized only briefly, I said. And then he went down. The blood pressure went down to 80. It should be above 90. Okay. And you start looking for other sources of bleeding. His abdomen is slightly distended. Okay. Yes, he's already intubated. And I have noticed, you know, children with some abdominal, bleeding, once you touch their abdomen, they have this discomfort, you know, look at their facial expression, even if they are intubated. Okay. And so in this case, he is having slightly distended abdomen and some pain. So what you will do next, as one of you said, FAST. What is FAST stand for? FAST is Focus Assessment Sonogram on Trauma. Okay, so we'll do FAST. Can we send this patient to CT? We said no. We shouldn't send unstable patient to CT. Be careful, please. I remember one patient, our surgeon, he forced us to send the patient actually to CT, and he said, I'm the one in charge for this patient. However, we told him this is against the ATLS guidelines. He said, well, I don't care about ATLS. They sent the patient to CT, and he arrested there. And for 45 minutes, they were resuscitating the child. And unfortunately, she died in an operating room because they decided to take her to OR to check, to open her abdomen, but it was too late. So you shouldn't send a patient, unstable patient, to CT. Do FAST. Very important. Okay. If you don't have FAST, what you should do? Okay, question. Okay, DBL, you are right. But this is, we don't do it anymore. Okay, but this is an option. OR, excellent. We should send this patient to OR. Okay, the surgeon for the decide to take the patient for emergency laparotomy, which revealed that this patient has lacerated spleen. This is what we, because the ultrasound, I didn't have the ultrasound report, but ultrasound showed there is some bleeding. Okay, so he was taken to OR, revealed lacerated spleen, which require partial splenectomy. And the patient after that was transferred to ICU, okay, and he was recovered well over the next few days. So this is very important. You see how bad the patient when he present to the emergency, but because we are well organized, we follow the ATLS guidelines, we save the patient. And this is the worst scenario we may face in our emergency, okay? And most of these cases, they recover when you do the right approach. So in patients who present with multiple trauma and shock, look for tension pneumothorax and relieve it immediately. And this is what happened with our patient. And don't intubate before relieving the tension pneumothorax. This is very important. Needle decompression of the pneumothorax should be followed immediately by a large pore chest tube, and look for ongoing bleeding in a patient who do not respond well to fluid resuscitation. And usually the areas, chest, abdomen, pelvis, or thighs, and also external bleeding, we have to mention it. This is very important. In hemodynamically unstable patient, FAST is helpful in identifying peritoneal free fluid and can tell us if there is an internal bleed, okay? And you should not send any patient to CT, and laparotomy should be considered, okay? DBL, as some of you mentioned, yes. What is DBL? Deep peritoneal lavage. You can put a needle and then aspirate, flush with normal saline, aspirate. If there is a significant blood, okay, that means there is an internal bleeding, but we don't use it anymore. It's not anymore, not longer, it's not anymore used as a standard of care in trauma victims. Never take an unstable patient to CT. This is very important. This is the second case. I hope I can finish it soon. 80-year-old girl who was struck by a car and she lost her consciousness and she was brought to the emergency department. On arrival, she was bleeding from her mouth. She has a shallow, rapid breathing, and her pulse rate 150, blood pressure 70/45, and she is very tachypnic, 35 per minute with normal temperature, saturating only 80%. How you will approach this patient? The same approach. Excellent. So we'll do the same, okay? You know, bleeding from the mouth, there is a broken incisor, broken teeth. So you have to clean the mouth. Airway is very important. So clean the mouth, and you have to consider also intubating this patient, but you have to make sure, is there a tension pneumothorax? Because you have to relieve it before you put your tube in, intubating the patient. There is a reduced air entry over the left side of the chest, but there is a breathing, okay, and normal percussion, and trachea were central. So what could it be, this one? In the left side of the chest, what could it be? Shallow, rapid breathe, reduced air entry on the left side of the chest with normal percussion, and trachea central. Hemothorax, yes, could be hemothorax, could be aspiration. No, what is the most common pulmonary injury in trauma? If you do CT for every patient with trauma, what did you for the chest? Contusion. Very excellent, Anas. So contusion is the most common pulmonary injury in trauma victim, and this is contusion. So you have to consider intubating the patient as soon as possible. She has also weak rapid pulses and deformity of the left thigh with an overlying deep wound, open wound. So what we should do, okay, we have to apply a pressure dressing and we have to give a bolus of fluid, okay? Excellent. So, and then we will go to D, disability, motor abnormal flexion, incomprehensible sound, eyes, no response to painful stimulus. So this is just how to calculate, you know, the Glasgow scale, which is around 7 or 6. So in exposure, there is a deformed left thigh, and some of you mentioned that there is a femur fracture, so we have to apply traction. Traction is very important. Why? Because so many reasons. First of all, it will reduce the bleeding and reduce the shock, okay? It will reduce the pain for the patient. It will reduce tissue damage in that area. So traction is very important to consider. Secondary survey, as we mentioned, there is slight distended abdomen, okay, on examination, and tender. So what does that mean? Okay, bleeding, excellent. So we intubated the patient, okay, and ventilated, and there was a neck collar applied. Oxygen 60%, the oxygen saturation was around 92. This is good. And we couldn't find a line, difficult IV line. So what we should do next? Quickly. IO, excellent, Anas. So IO inserted and given bolus of fluid. Can you give all the medication through IO? Everything can be given through IO? Medication, fluid, everything? Yes, absolutely right. Good. So we can give fluid, we can give everything. So after giving IV and IO, IO fluid, we notice that this patient, he is doing very well, and his blood pressure improved to 90/60, and the pulse rate reduced from 150 to 110. Okay, so pupil were reactive, Glasgow Coma scale 6, left femur open fracture. What we should do for this left femur open fracture? Initially, we should apply immediately pressure dressing to stop the bleeding, ongoing bleeding, because this is one of the areas that can cause continuous hypotension, you know, because of continuous blood loss. Secondary survey, most likely abdominal fissular injury. So what we should do next? The patient is stable now, but we need to know, we feel like he has a tender abdomen, fast, excellent. You can consider fast. Can we send this patient to CT? Yes. Anas, Zainab, excellent. Yes. Sharif. Very good, Abdullah. So we can send this patient to, we can do fast, okay, if it is available there, and we notice there is some internal bleed, but still we can send this patient to CT because he's stable, okay, hemodynamically stable. So this is the X-ray was done for C-spine. It looks normal. Okay, chest X-ray, as you can see, the left side, there is a contusion. This is the typical finding in the chest trauma. Oh, this is the femur. You can see it's a fracture. Patient sent to CT as you recommend, okay, because he is stable. And you can see here, it's shattered, you know, spleen. Okay, this is a spleen. Okay, and there is some bleeding. Okay. Oh, CT brain also done. What does that mean? There is, okay, punctate bleeding. Okay. So this is a severe indicate that there is a severe head injury also. Okay. So injury identifies severe head injury, pulmonary contusion, okay, and shattered spleen, upper left femur fracture, which was put on traction. So surgical on-call arrived and he discussed the case with you, and he said we don't have the facility and he need a pediatric surgeon and PICU, which we don't have it in our hospital. So what you should do? Please, because we don't have time. Oh, we are already over time. Okay. I hope Dr. Saleh is around so we can finish quickly. So the most important, we have to arrange, as Darren mentioned, for transfer, and this is the referral. When you refer any patient from your hospital to another hospital, you have to give a detailed, okay, history and report, and mention everything. And you have to secure a definitive airway, very important. Can we allow one of the family to accompany the patient in the ambulance? Yes, we can. Excellent. Okay, and we have to have a well communication. So this is very important. The patient was transferred safely, okay, and he was taken, shattered the spleen, serial hemoglobin checks, close observation. He didn't need surgery. That's very interesting. Most cases does not require surgical intervention. Very interesting. And pulmonary contusion, good oxygenation and ventilation. This is the treatment. And you have to avoid over fluid, because sometimes with pulmonary contusion, it can cause edema. Severe head injury, ICP monitored, okay, in the ICU, very good. And open femur fracture, surgical debridement, and internal fixation done for this patient. So this is a home message. Any case of severe head injury must be intubated and ventilated using a sedative and muscle relaxant, and you have to call for help in case you face difficulty in airway management. Pulmonary contusion is the most common pulmonary injury in children. Other life-threatening injuries should take a priority over severe head injury, like, you know, abdominal trauma, femur fracture. So sometimes we call it like a distracting fracture. You ignore the other injuries, which is more serious. It causes more bleeding than head injury alone. Very good. Most abdominal visceral injury in children, they require only conservative management. Medical transport is a big risk process, but you have to make sure the patient is stabilized before transport and accompanied by a competent physician. So in summary, the management of multiple trauma require a good multidisciplinary care. Always apply the ATLS guidelines of primary and secondary survey. In shock multiple trauma patient, always look for tension pneumothorax and relieve it immediately before intubation. Most abdominal visceral injuries are treated conservatively. Any questions, please? Khulud, if you could please contact Dr. Saleh and make sure he is ready, please. Okay. Any question, guys? Let me see. While Dr. Saleh prepare his slide. Wait, I think there was a question before. I cannot did someone made a question? I think, oh. Okay. If we don't have facility to stabilize the patient, can we transfer like stab wounds, severe bleeding? Of course, this is, but you have at least to stabilize the patient as much as you can. I know sometimes it is difficult, but you should use ATLS guidelines, okay? Apply pressure dressing and do the best you can do and take that way very, most welcome. Any other question, please? Okay. Thank you.
طيب. أولا نبدأ بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا وحبيبنا محمد عليه أفضل الصلاة والتسليم. I'm going to start okay, good. Alhamdulillah Rabbil Alamin. Good. I'm going to start this sessions about cases can be missed that will not be allowed to sleep. I'm not talking about something scary movie or something like احنا بنتكلم عن common malpractice or common practice that we do it inside the emergency, and that will lead you to mistake, either intentionally or not intentionally. This is the issues here. In the next 30 minutes, inshallah, we'll talk about few cases here, but let me talk about the cases, common malpractice in the United States. This happened in 2017. We'll talk about pediatric malpractice coming in number 4. The number 1 is neurosurgery. Actually, the levels is different from time to time. If 2017, 2018 coming, sometimes gynae will be number 1. So الترتيب حقه يعني بيختلف من سنة لسنة. Malpractice lawsuits here. 1/3 of American Academy of Pediatric members had their name in the lawsuits. Emergency department is a high risk area. Why? Why high risk area? Because it's overcrowded. Sometimes we have open gate. The door never we can close it there. 85% of the suits involve in the night shift, especially if there's some practice and some physicians, they're taking frequent night, 5-6 nights sequential, and this will lead to his thoughts and critical thinking will be affected. Most of the cases had been solved outside the court, and 10% reach to the jury, alhamdulillah, Rabbil Alameen, maybe less than 10%. So we'll talk here how to avoid this. Actually, many points we can avoid it simply, either by documentations, clear communications with the families, giving them legal or appropriate appointment if they need for urgency, either in the primary care or subspecialty, if we need it. Because you don't like to keep the emergency gate for all the subspecialty, and this will lead to more patients will come to ask for the subspecialty there. High-risk cases in pediatric emergency here, number one is missed meningitis, also missed appendicitis, fractures, testicular torsions. Also, outside the textbook, there's also interceptions. Kawasaki can be missed. Wound complications, also as an area for malpractice here or high risk. Medications errors, especially when we're having a big number of patients coming to the emergency and we cannot sort them out, and sometimes by mistake we're giving medication to someone else. Myocarditis, one of the common mistakes can be missed in emergency because sometimes we deal with it as gastroenteritis, for example, patient lethargy, doesn't like to eat, vomit, or simple diarrhea, looks pale. And we go through it, this patient having initial steps of myocarditis, dehydrations, and actually some study mentioned that most of the kids who present to the emergency, they've been discharged with underestimate of their hydration state, dehydration. So why people complain here? Either they're having bad outcome for the case, negligent care, or poor communication. Why people here sue, asking or complaining here? Because they're asking either for money. Let's talk about all the cases, but not all of them, of course. They are because if they're angry, they feel guilty. They came late to the emergency with their kids, and they feel guilty, so they want to displace the blame to the others. They want to save next patient, relative. Actually, this is one of the, maybe in our culture here in Saudi, either can their relative is physician or something, they will ask them, go and complain against this doctor. This is malpractice. And sometimes, most of the time, it's not so that clear mistake. But sometimes they're having advice, unfortunately, from inappropriate person or the physician in the family. So advise them to go and complain and read and advice from another physicians here. They went to family physicians or OBD, why the AR did for you like this? This is not common practice. They're supposed to treat you there. Why you come here? You are come late to us here. So he will ask them to go and complain against that physician. This is not supposed to happen in our culture. We're supposed to be our family area, not happen that. And I'm sure إنه حصلت مع كثير منكم يعني. Here is the emergency here, وفي new triage مسوينه الحين. New triage scores. It's our new method for determine who we should be treated first. Who shout and the count sound intensity high, هذا راح يشاف أول واحد. من اللي بيصيح اللي shout من اللي complain هذا اللي راح يشوف أول واحد. We take people in order of how loud they scream. Excuse me for half a second. So here's patient why he's angry, or he may be some watcher in the emergency, the waiting area, because this patient is waiting for a long time. So actually their study, they found the waiting time maybe this one of the leading for anger of the patient from the emergency and lead to satisfactions, and they will complain against us. So the doctor will be with you in just 5 more minutes, and he's already died here. Why the people also complaining against us? Because those huge number of people, they are waiting in line, and everyone think he's supposed to be in the first line, and he's the most sick one, and supposed to be seen. If you're not being seen first, he will be complaining. So let us discuss some point here and how can we avoid this. Why us in emergency here? Long waiting time, impersonal registrations, brief contact with the physicians, connection is not established, and the physician strain. Please be careful about this physician strain here. When you looks hurry and looks anxious, and you are not in mind that you're listening to the patient carefully, even if it's crowded area, this will be dissatisfied the people from you. Even they will not be happy with your treatment, whatever you will do. Once you looks hurry, anxious, strains, inappropriate dress in front of them, either you or their trainees or the residents, the people, they will not be happy, whatever you will do. Even if you've been your maximum effort for the patients. Don't be looks hurry and appropriate. This is one of the bad behavior sometimes we do it in front of the patients, because we are strains and we're complaining from the systems and complaining from the nurses or something. Stop that in front of the patient. Maybe they will complain against you. احنا دائما نقول يعني معلش I will speak a little bit in Arabic. يعني احنا ممكن نكون مبتلين وابتلانا الله عز وجل في اشياء كثيره في الطوارئ في هذه، لكن لم نؤذى مثل ما أوذي الرسول صلى الله عليه وسلم. يعني we should be maximum effort for us to do the maximum best for the care of the patients and to be very, very patient in front of the people. This is our emergency here. Who work in emergency, they have special characters. They have the maximum tolerance for the stress. They are happy usually, and people who work in emergency, they look happier than others because they are serving a lot of patients. They having the maximum tolerance to the stress. They are always smiling. So not everyone can work in emergency. There is a special character for the physicians or the nurse or paramedics who can work in emergency. Those people, يعني زي ما يقولون صدره شمالي, أو he's the most comfortable area for him, this area. So not everyone can work in emergency. Only special characters who can tolerate to the high stress area, and at the end of the shift, he's very happy and satisfied from his work. Look to these pictures. The people before coming to the emergency, they think about these pictures. EMT, he will push this patient aside. Hot pizza, yes. Harry, can we see this one? Bathroom, where is it? A lot of sound, procedures, no privacy, and this patient looks very scary. Strategy to minimizing the risk here. How can we do it in the next few slides here? Practice good medicine, communicate well with the parents and patients and other specialties. The communication is very important. You need to communicate very well with everyone in the emergency. This will be make your life very, very easy. Another point here: document. This is maybe I will tell you this is very, very important. It's number one in emergency. If you don't document it, that's meaning it's not done. You need to document everything in your file. What's happened to the patient, you need to document it. This is the best protect for you in any complaint against you. Good practice, act reasonably, consider the other concerns, and sometimes also I want to add, believe what's going on in your gut about this patient. Look for red flag in history and exams. Focus on the persisting vomiting and lethargy. Be careful, maybe something else, not gastroenteritis. Sleep child it's the same like a sick child until you've been wake him up. So that's meaning I will estimate his GCS is low until I can fully awake the child, even in the night shift. Be careful from sleepy child. Maybe toxic, something else. Arrange for follow-up, look for improvement. Don't make lots of excuses for the patients. Just explain the things, but don't make sorry, that's happened because the labs nurse doesn't like to listen. We have a lot of patients. This will be maximizing the stress to the patient, and the complaint will be more. Good practice here, follow the policies and protocols inside the emergency. Supervise the trainees. Supervise the trainees is very important here, because lack of supervision, that means medical errors, and will go back to the team leader in the shift. So be careful about this point. Let us discuss it case by case. 13-year-old boy present to the emergency department with abdominal pain. He took paracetamol to relieve the pain. No history of trauma, allergy, and food. Past medical history is none. Having right lower quadrant pain since last morning. Nausea and vomiting, no bowel motion since 2 days, and fever is 39.3. What's going on with this patient? What do you think? Okay, appendicitis. So everyone agree about appendicitis. So pain mostly in right lower quadrant, better with movement, history of burning, micturition when he passing urine, but urine analysis was normal. Vital signs 39.3, pulse rate 98, RR 24, weight 44.6, blood pressure 122/82, head and neck benign, chest clear, abdominal positive, bowel sound. There's tenderness clearly in the right and left lower quadrant, no rebound, no mass. Rectal exams was normal. And this is the X-ray. Believe it or not, that's what happened to this patient. Small calcified mass in the pelvis. What we call it this? What we call it this? This is called appendicular mass. It's pathognomonic for appendicitis. Once we see it, no need to do ultrasound. It's already there. This is appendicitis. But they think because the situations maybe could be renal stone, appendicular mass, office reading appendicular mass cannot be ruled out, CBC, renal profile, urine analysis was normal. So the questions for everyone, what is this case? Which is clearly for everyone. Okay. So here will be a little bit confused who read it. Is it most likely there's a clear stone supposed to be in the kidney, so is renal stone. Repeat urine analysis not normal, given acetaminophen, patient improve, IV fluid, re-evaluation, oral intake is getting well, the pain much better after paracetamol, the abdominal tenderness getting better. So after the hydration and pain analgesia, the impression was renal colic, maybe acute gastroenteritis. This, by the way, the case reported in the United States. This I taken from Blue Suits documentation there. Case one had been discharged with instructions, encourage oral intake, and given ibuprofen. Let me ask you a question here. Is it appropriate to send the patient with query appendicitis on non-steroidal or query appendicitis? Why? Why? Everyone say no, no, no. It's good for pain. But why ibuprofen? No. It will mask the pain. It will mask all the inflammatory process. Okay, by the way, patient discharged home, alhamdulillah, and came back with appendicitis perforated, and hopefully, alhamdulillah, had been survived and given to the OR. So the trick point here, don't read the X-ray quickly. This is a common bad practice in emergency. We are reading the X-ray quickly, and sometimes we are not looking to the names of the patient or MRI number. Consider abdominal ultrasound, CT scan. If you have any doubts, don't be hurried to discharge the patient to take the next patient. Re-examine the patient, document it carefully. Admit patient if classical history, impressive exams, or abnormal lab. Don't try to discharge the patient, just refer him to the surgery. Case number 2, you have any questions? This is a simple case. 14-year-old girl, shortness of breath for last hour, past medical history, asthma, vital signs, temperature 39.2, pulse rate 112, respiratory rate 40, and blood pressure, 120/90. Alert and dyspnea. There is numbness in the hands and feet. Lungs looks clear. The child having, or the patient having left shoulder pain and left lower quadrant pain, numbness, tingling fingers. He having difficult breathing. Now complaining from pain everywhere, history of seen by psychologically in the past. So this is the patient, he's 14-year-old, having shortness of breath, he having fever, tachypnea, dyspnea, numbness, and then he having left shoulder pain, left lower quadrant pain, then having pain everywhere, having difficult breathing, and now we having history of psychology in the past. What happened? In the exam, he looks anxious, he looks upset, skin warm, dry, chest and exam was normal, abdominal soft, he having left upper quadrant tenderness, extremities pulse are full range of movement. After 1.5 hours, she feel fine and want to go home. Abdominal was soft, joint was normal, X-ray negative, assessment was, what is this? Viral infection. Let me take point here. Be careful when you diagnose the patient with viral infection. That viral infection, that means you already discovered the viral infection and there is a source for fever that make you the viral infection. So be careful about this diagnosis, viral infections. If there is no source of infections here, don't just blame the viral infection, maybe the cause because I couldn't find it. You can put fever for investigations, no source of fever unspecific, but don't make specific diagnosis and you are not sure about fever infections. The plan to recheck the patient after 3 to 4 days. At 11 p.m. patient will be at wheelchair, discharge طبعا home. الساعة 11 الليل, the child was in wheelchair at home. Parents were unhappy. In AM, she's unable to stand. She went to ED by the ambulance. She's blood pressure is coming down 90/64. The pulse rate is coming up to 120. There was a purpura crash. So the initial diagnosis was Hemorrhagic purpura. So what could be this diagnosis? Fever, hypotensive, purpura crash. What could be this one? What could be this one? Meningitis. Why meningitis? Okay, let me go here. This meningococcemia, not meningitis, meningococcemia. Even if we're having some vaccination or something, but still meningococcemia is there. It's not clear. This having the patient will end up with bilateral below knee amputation. Was CBC indicated here? Was the diagnosis reasonable? Was discharge appropriate? Was outcome altered here? Meningococcemia is difficult to diagnose, but be careful about it. It's still there, maybe present without rash, 16% present with wound and back pain. Avoid diagnosis of flu if no URTI. Don't discharge if the patient is still having severe pain. Severe pain, cannot be amputated, he looks sick, high-grade fever there. Don't hurry to discharge the patient home. You don't know what's going on there and what's the process or the course of the disease with you. Case 3 is 2 years old, male with no past history of present to the emergency department with altered mental status. His mother reported that she found him rolling on the floor with the kitchen 2 hours prior to the presentation. طبعا الchild who looks very warm and dry and is unable to ambulate. She's also mentioned he was very irritable, couldn't focus on her, or he was reaching out of things. يعني هو الولد was staring something and looks hallucinated. She mentioned she found a couple of household cleaners near to him alongside his old brothers. وطبعا she suspected انه he just something or his old brother give him something. So physical exams, his febrile 38, heart rate 140, respiratory rate with blood pressure is a little bit hypertensive. Generally, he looks irritable toddlers, staring, head and neck extremely dilated, reactive pupils, pharynx looks dry, chest is clear, and abdomen looks absent bowel sounds. Case progressive, giving physostigmine just for those maybe having anticholinergic or organophosphate. So he's giving the dose of 0.2 milligrams per kg. It was administered over 5 minutes, after which there was no change in the mental status, vital signs, or clinical presentations. Second dose, physostigmine given, and there is a resolution for papillary dilations and encephalopathic behavior. So let me go what's going on here. Toxic screen had been sent for salicylate and ethyl glycol level were negative, but here the paracetamol was high. You know, all the presentation here for anticholinergic effect, or he maybe ingested something organo or antihistamine. But by the when we did toxic screen, it's been positive for paracetamol, and paracetamol level was high. So what is this? That's why we need to be careful about combined drugs. So this patient started in a N-acetylcysteine loading dose and admin to the PICU. And this, unfortunately, he ingested this one. So we think about something toxic, but the paracetamol, we will not have the effect of toxic of paracetamol now. We will have affected later on. So here, the benefit of doing toxic screen. The child was actually getting combined medication. It's both diphenhydramine and paracetamol. Take home message here, always think about aspirin and paracetamol ingestion of suspected accidental and intentional drug toxicity. And case number 4, about the communication here. This 15-year-old feeling terrible, 3 times visit to the emergency, and always be careful about written visit. Diagnosed flu, atypical pneumonia, stress, mother want admission, admitted elsewhere with a bad pneumonia. There will be failure to communicate, 70% of malpractice due to the communication issues, communicate style, clinical attitudes. There was inadequate explained diagnosis. حنا لنا في الطوارئ always we briefing, explain everything for the patient. Fail to understand the patient and family perspectives, patient felt rushed. And I'm always advised, be careful about this point. Whatever the load in your head, it's only 8 hours and you will finish your duty. Families who complain about dissatisfaction from doctors, 13% of doctors wouldn't like to be listened to us. 32% of doctors doesn't talk openly. 48% doctor attempt to mislead. 70% doctor didn't warn about the outcome. So the skills here that we need to have it, satisfaction, look always to satisfy the patient, consider professional training, patient advocate helps, triage and registration is important here. If you have a good triage, good registrations, that will make the patient comfortable, and maybe someone will let them know what's the process or how long you're going to be till be seen by doctor. This will be very helpful for the patient and will let the people a little bit anxiety will be getting better. Unhurried appearance, dress, posture, manner. يعني ما تجي وشعرك طالع واللبس مش كذا والريحة يعني برضو كمان ما أنت proper dressing as a physicians. Demonstrate compassion, apologize for wait time, listen well. It will not take more than 5 minutes, 10 minutes. Speak clearly, simply. Hide your own anger بالذات لما يكون عندك stress مع التيم او مع السب سبيشاليتي. be careful لما تحول حاله ولا شيء وما عجبك الرد وكذا لا تبينها قدام المريض ما له ذنب في الموضوع. Tell family what to be expected, keep family informed, don't blame others. والله التبريد ما قاعد يسوي شغله، والله الاداره ما قاعده تسوي شغلها، والله انه الدكتور فلان مقفل جواله. يا اخي don't blame the others, try to find something else. البيرنينج حيصير داخل المريض نفسه، حيخاف انه جاء هنا، يمكن استغفر الله العظيم حيندم على اليوم اللي جاء فيه دخل المستشفى فيه. Avoid joking, stray comments, sometimes inappropriate words unfortunately between the health team. يعني ما نقول يعني حدث ولا حرج اللي بيصير هذا، وقدام بالذات البيدياتريك ايج we don't like it. احيانا والله انا بشوف احيانا inappropriate words والله تنعطى قدام المرضى، حتى تشاهد يعني he's shock احيانا من التوك اللي احنا بعض التيم بيتكلمون قدام المريض. came angry the family زعلانين ولا شيء. شوفهم ليش most of the family they don't come here for fancy things, they are coming for يعني for their highly needs for that. Discharge instruction, when to see the primary care physicians, when to return immediately, review written instruction and obtain signatures. طيب, medical record is one of the important things in emergency. You need to document everything. This is your best defense. If you do your maximum effort for the patient and you didn't document it, I'm the one patient, I can claim against you and I can take your money. معلش الكلمة هذه, لكن you need to be careful about documentations. Everyone will believe your written record, not your tongue. Only what you written here. They will believe your hand, what's written there. Nobody will believe your tongue when the problem started. Recommendations for documentation. Carefully document history of illness and injury. Physical exams and vital signs, be careful, always mention it. عشان كذا النيو سيستم اللي الآن موجود الآن for health records, it's always including the vital signs for documentation. Time of the exams, order, procedures, patient change for improvement, reassessment. Did you refer the patient or not? What's the time? What's the response? Always tell the chart everything. Tell the chart everything. Don't tell me. Don't tell your seniors. Don't tell your juniors. Don't tell the consultant. Tell your document everything. Don't go home alone. Be careful about this. Recommend for documentation. Careful document. Conversations with the consultant. Report the procedure. Diagnose impression. Discharge instruction. Dispositions. Don't go to the court alone. Write everything in the documentations. Sometimes say الصوت واضح ولا؟ طيب في documentations, if you're using paperwork, don't be bottle with your or don't fight with your paper. Do like this. That everyone will believe that you change your documentations. This is dangerous practice. Be careful about it. Don't black out or erase. Don't use abbreviation. Nobody can understand it because nobody will believe it. Don't use unnecessary term. Alter the chart later. Be careful. There is a picture already done from this one, or there is documentation already done and sent there. Once they say it or they review it and they found some change in the documentation, this will be against you. نقطة مهمة دائما أقولها في documentations. I'm always see the patient. I maybe see the patient within 5 minutes, but the documentation will take from me 10 minutes or 15 minutes. Usually the documentation will take double the time with the patient. Telephone management. Also be careful about it. واحد بيتصل عليك وبيطلب منك recommendation by phone instead of the emergency. انتبه. Advantage of telephone, many patients love to call the physician, sometimes for officers, practitioner, but it's not for the emergency physicians. And your job just to tell them come to the emergency. This is a case, mother called, 13-month old boy, 3 days history of chickenpox, now fever, bruise. The physician didn't bring in for the visits. child died from group A, streptococcal sepsis, following the varicella, no record for the phone call. الأم قالت والله كلمت الدكتور وقال لي اقعدي في البيت وخذي فيفر، هذه تشيكن بوكس واضحة. اللي حصل إنه أدينا الطبيب فيها. Mother called, teenager's son had scrotal pain. Nurse said, doctor would call you back. الأم انتظرت ما حد رد عليها. No one called back. Testicular loss from torsion. ودينا التيم فيها. Disadvantage of telephone phone that you cannot make history complete. Physical exams is impossible. Manual distraction emergency. Instruction may be dismissed and understand. But documentation here is difficult. Well, follow-up also is very difficult here. The indication for phone here called, it's mainly to tell them where is the nearest ER for you أو primary health care حتى ما تدخل في مشاكل. بس إنها مفيدة في حالة البويزنينج, so you can tell them how to do the ABC, life threatening, also how to initiate CPR لا قدر الله, help patient to get access to the care, either primary care or the emergency. Patient who just left the emergency department, so possible for written visits, what's the red flag or warning signs came to the patient at home. Always tell the patient to come to the emergency department to be in the safe side, and the triage will sort it out for that. بس حيكون أفضل من إنك تقول المريض لا تجي وتصير مشكلة في البيت لأنك ما بتشوف أنت you are listening to the patient, you didn't examine the patient. Telephone call, don't try to be a Superman. Don't try. Dama, it's a common practice here in emergency. طبعا لأن الدامة واللامة طبعا حتأثر على سمعة المستشفى, والدامة راح تأثر على الديسيشن حقك, لأنه الفاميلي maybe they will go to somewhere else and they will find a different diagnosis when they are forced them to sign دامة. فهنا حتصير المشكلة إنه أنت الدياجنوس حقك مختلف تماما عن الدياجنوsis from another health institutions, and the problems will start to be at the side. So best to avoid it. Try to explain to the patient everything. Document everything in the file. If it's high risk, you will say high risk like that. Put all possible investigation and the diagnosis there. Another physicians in another hospital maybe help or take clearly history. 1 minute, please. Sorry for this interruption, but because I have urgent call now. So DAMA, best to be avoid, establish rapport with the parents. Another physician in other hospital maybe help or take clear history, and they will change your diagnosis. انتبه منها. Document the scenario, invite them to come back. When DAMA not allowed, when you suspect child abuse, life-threatening, parent disoriented. انتبه منها هذه. There is no not allowed DAMA فيها. There's a lot of points, but this is the main point. DAMA here will not be allowed. Tips: use caution, chest pain, abdominal pain, fever, هذا vague diagnosis. Use caution if the child cannot be ambulated. Care given by the others impact on you. Shift change and handover, هذا أخطر وقت اللي هو change of the shift. هذا يسمونه dangerous time. If consultant need, insist for help. Vomit is not always GI pathology. Postpone LB if infant is in distress, لأنه كثير من المورتاليتي والموربيديتي بتصير إن إحنا we are insisting to do LB, we are delaying the antibiotic, والpatient is distress, and the child unfortunately في حالات died. Child was distressed and we are insisting for LB, CO2 accumulations, whatever, metabolic rate is bad, acidosis, we are delaying intervention with intubation, everything, and the child he may died on table because of the LB, insisting to do LB on time. So postpone that LB. You may take up to 24 hours to do LB. Still, even you start ceftriaxone, CSF will not be clear إلا بعد 24 ساعة. Ask for help with complex wound. انتبه منها. We don't know, maybe tendon issues, infected, abscess, bone infections, injury. Read the notes of the others. Describe the patient improvement on discharge note. Listen to and talk with your patient. Provide high quality care. Document carefully. I don't like these pictures. I'm not sure Dr. Conway understand how these loan forgiveness programs work. Thank you very much, and I'm happy to receive any questions.
the different type of shock, how to make good differentiation between the different shock, and how to manage and select good approach for this patient. So shock is can be it's very difficult. It's acute and very complex states that can be facing in the ER. So it's very complex state of circulating dysfunction that results in failure to deliver sufficient amount of oxygen and other nutrients to meet the tissue metabolic demand. And this shock is a dynamic process, so it can be changed with the time. So this patient, you have to be good reassessment and evaluation, and check the vital signs frequently to be sure how is the patient progress. There is some the important definition. Some you have to be familiar for this one. What's meaning of fluid refractory shock? This patient, he's still in shock despite that's giving 60 ml per kg in the first hour. And dopamine resistant shock, he's giving, he's still in shock despite this adequate fluid resuscitation in the and started in the 10 microgram per kg per minute. Catecholamine resistant shock, is still in shock despite of the epinephrine and norepinephrine started. Refractory shock, this is patient still in shock despite this goal-directed use of the anitropes agent, vasopressor and fluid, vasodilator, and also the maintenance of the metabolic and hormonal hemostates. So shock is a syndrome that results from the inadequate oxygen delivery. Oxygen delivery to meet the metabolic demand. So oxygen delivery is less than oxygen demand or consumption. Sorry, this patient, he is in shock. If untreated, this lead to metabolic acidosis and oxygen dysfunction and death for this patient. But if you go to more details about what's the factor affect the oxygen delivery, this will be affected by the cardiac output and arterial oxygen contents. So the oxygen delivery will be calculated by the cardiac output multiplied by arterial oxygen content. So cardiac output also, there is two important factors for this cardiac output: heart rate and stroke volume. And also the stroke volume, you can determine and affect by the preload and afterload and contractility of the heart. So arterial oxygen content will be equal the oxygen content of the RBC plus the oxygen dissolved in plasma. So finally, you can find that the oxygen arterial content will be equal the hemoglobin multiplied by saturation multiplied by the constant 1.34 or 34 plus the pressure of the oxygen multiplied by constant 0.003 to calculate the oxygen arterial oxygen content. So at the end, you can find this one, the oxygen delivery to the tissue will be the factor, also the blood oxygen saturation and the cardiac output. Blood oxygen saturation will be affected by hemoglobin level and also blood oxygen saturation. Blood oxygen saturation will be affected by three important factors: the airway, breathing, and giving the oxygen to the patient. The cardiac output will be affected by the rate of the patient, or the heart rate, and the stroke volume. Also, the stroke volume will be affected by three important factors: preload, afterload, and contractility of the heart. So when you present the patient in shock, he can be present as a compensated shock or decompensated shock. If he is patient present with a compensated shock, that's meaning the patient is systolic blood pressure within normal range, with the sign of and symptoms of inadequate perfusion. So this is the difficult part and difficult cases. He is present patient with compensated shock and blood pressure is maintained. So children is more often present in the compensated shock. You have to have higher alert and clinically assessment to be sure in this patient he is clinically good, matching with this patient he's in shock or not. At the end, if he not manage, he will be present or he will be progress to be decompensated shock or hypotensive shock. So sign of the shock will be associated with the systolic hypotension. So this patient usually in the beginning will be patient present in the first hours, will be patient try to maintain the blood pressure. If you're not discovered early and managed, will be the blood pressure will be dropped. Also the cardiac output in the first will be try to compensate, then will be the end will be decrease and will be not maintain the cardiac output. But about the vascular resistance, in the beginning will be try to be maintain this vascular resistance, then after change the blood pressure and cardiac output to be decreased, then the vascular resistance will be increased. Okay, to compensate and to maintain the perfusion. So early diagnosis required to be high index of suspicion, and diagnosis is made through the physical examination and focus on the tissue perfusion. So hypotension is the late and this is a pre-morbid sign, and this is the difficult phase can be managed in the patient and increase the mortality if the patient present with hypotension. What the initial evaluation can be and what the physical examination finding can be in presented the shock. First, neurological finding will be patient change in the fluctuation of the mental status and will be decreased sunken fontanelle. Then will be fixed the maybe patient developed the neurological finding for this patient, and this is one of the important end organ can be affected by the shock. Then you can find also the skin and how's the skin and extremities for this one. His cone, patient pillar, motility skin, cyanosis can be present with the poor capillary refill or weak pulse or poor muscle tone. And also you can make good assessment for cardiopulmonary if we patient present with the tachypneic, tachycardic. It's very important. At the end, you can make good assessment for renal. How is the patient passing urine the last 24 hours? If it's low volume for the urine, this organ is affected the renal, or concentration of urine increase due to that decrease the perfusion to the renal. What the equation can be give just roughly what's the lowest or the lower limit of the systolic blood pressure, usually using that 70 plus to multiply the age a year. This one equation can be used up to 10 years. But neonate usually accepted to up to 60, no problem. For infant, from the 1 month to 1 year, we accept up to 70 for this patient. So how can calculate or can be find the pulse pressure for the any patient? Just to the difference between the systolic and diastolic blood pressure. And normal diastolic blood pressure usually equal to 1/3 of the systolic blood pressure. If the patient present with the narrow pulse pressure, that's meaning low stroke volume and high systemic vascular resistance, or maybe both. This can be present with a cold shock. The warm shock in the sepsis, usually patient present with what? low systemic vascular resistance for this patient. If you mention this patient wide pulse pressure, that's meaning the systolic blood pressure is less than half of the systolic blood pressure. It's very important to find what's the past medical history of this patient. It's very important to check what's about if the patient has history of heart disease, surgery, steroid use, or medical problem. And you can take a brief history of the presenting illness, what's the exposures, what the onset of the symptoms. It's very important to make a brief history from the parents. The different type of the shock, there is different type of shock you can be find in presenting in the ER. This hypovolemic shock is the most important shock type. Can be present due to hemorrhage or fluid loss or burn. Also, cardiogenic shock, distributive shock can be due to sepsis or anaphylaxis or drug ingestion, or maybe obstructive shocks like tamponade or pneumothorax or pulmonary embolism, or patient present with the congenital heart disease. Some congenital heart disease can present as obstructive shock. Neurogenic shock, dissociative shock is very important. So it's very important to be familiar for all the types of the shock when you make good assessment, to be the good differentiation between all that type of shock when you manage the patient. Right. You have to make good, precise etiological classification, maybe delay. So it's very difficult to manage the patient, and sometimes maybe not easy for you to make good differentiation between the type of shock in the beginning. So you have to be start the initial management and make good history for this patient to be sure that can be differentiate that type shock and what's the good steps for you to start it for management of the shock. Immediate treatment is very essential. Absolute or relative hypovolemia is usually present for this patient. It's very important. I think this is a difficult one, but you have to be familiar for this one. If the patient present with the hemorrhage, or like burn or fluid loss, or the patient present with the third spacing, he is present with the hypovolemia. This will be defect the preload and decrease the preload. That will be decrease the effect of the cardiac output or decrease the cardiac output. The sepsis this usually is very difficult. Is not easy for you to understand the mechanism of this one. Sepsis sometimes can affect the hypovolemia and can decrease the preload. Also can decrease the systemic vascular resistance or increase the systemic vascular resistance. If you decrease the systemic vascular resistance, like in the warm shock, would be decrease the afterload and decrease the coronary perfusion. If you are speaking about cold shock, increase the systemic vascular resistance and increase the afterload, that will be decrease the systolic function. All this will coronary perfusion decrease or decrease the systolic function will be affect the cardiac output and decrease. About the cardiogenic shock would be increase the systemic vascular resistance and decrease, that's when we increase the afterload and decrease the systolic function. Also can decrease the cardiogenic, the myocardial depression, and decrease the cardiac contractility. This will be affect the systolic function. Also, the cardiovascular obstruction or obstructive shock can increase the systemic vascular resistance, and that will be affect the myocardial depression. So if you decrease the effect of cardiac output or decrease the effect of the cardiac output, will be decrease the blood pressure. This will be increase the cortisol production. That will be affect the sodium and water retention for this one. That will be increase the vasoconstriction for this one. Also, this will be affect or decrease the renal perfusion and increase the sympathetic discharge and increase the circulation of the catecholamine. So, patient present in the neonate in shock is included in your differential. Usually, you have think about cardiac or congenital adrenal. Congenital adrenal hyperplasia, inborn error of metabolism, or patient present with the obstructive left side cardiac lesion like aortic stenosis, hypoplastic left heart syndrome, coarctation of the aorta, or interrupted aortic arch. What's the goal management? It's very important. Goal management to increase the oxygen delivery and decrease the oxygen demand. It's very important. For all the children, you have to improve the oxygenation, give fluid if you need, accept the patient is in cardiac or cardiogenic shock, monitoring for temperature and make good temperature for control, and correct the metabolic abnormality. Also, is depend on the suspected cause. If he's septic, you think about the septic shock, you can start antibiotic in the first hour, and you can see if the patient is not responsive for fluid. You can start an antibiotics, or maybe this patient he's not improved the saturation. You can start patient on intubation and mechanical ventilation for this patient. So it's very important to make good assessment for airway. If he's not protected or unable to maintain, you can be intubate the patient and start mechanical ventilation. Breathing, always give oxygen 100, start with a breather mask, and you have to make good monitoring for saturation. Circulation, you have to establish IV access rapidly and give fluid, monitoring blood pressure, and make good cardiac monitor for this patient. And if you give any fluid, you have to make good frequent reassessment for this patient to be sure the patient not worsening the vital signs. If you request blood test for this patient, you can request blood gas, blood sugar, electrolyte, CBC, BT, BTT, and type of the blood or blood group, and cross match, culture. You can request all the liver function test for this patient. It's very important for management to optimize the preload, normal saline and lactate. You have to start it in the beginning, okay? Except the patient is in cardiac shock. Except for this myocardial failure, you have to use 10 to 20 ml per kg every 5 to 10 minutes, and you make good frequent reassessment after every bolus. When you reaching this 60 ml per kg, consider ongoing close or adrenal insufficiency, or maybe intestinal ischemia or obstructive shock. So think about other differential, and you can manage your make different management according to your assessment. It's just X-ray for this patient to be sure the patient not developed, or maybe not cardiac case. We need to be going for enterops if the patient not to improve the blood pressure. So first 5 minutes, you have to be recognized, decrease the mental status of all this patient and perfusion, and you have to maintain the airway and establish access according to the PARS guideline. Then, if the patient he's not recognize this patient shock, you have to push 20 cc per kg isotonic saline or colloid bolus for this patient. You can offer 60 cc per kg and correct the hypoglycemia and hypoglycemia, hypocalcemia. So if you, after 15 minutes, you find this patient, he's still in fluid refractory shock, you can establish central venous access. You can begin dopamine therapy and establish arterial monitoring for this patient. If a patient still has fluid refractory and dopamine resistant shock, you can titrate and start epinephrine for cold shock, or norepinephrine for the patient with the warm shock. If the patient not improve, that's meaning it is catecholamine resistant shock. You have to ask yourself, if he's think about adrenal insufficiency, you can start the patient hydrocortisone, or patient not, you can no need for start this one. If the patient normal blood pressure and cold shock, you can check for the saturation in a systemic venous central line for this one. If he is less than 70, you can add a vasodilator, or you can start the patient in type 3 phosphodiesterase inhibitor and with volume loading. If your patient still in blood pressure is low and cold shock and systemic vascular central systemic vein concentration for saturation is less than 70, you can start patient in titrated volume and start patient epinephrine. Patient low blood pressure with warm shock, you can start on norepinephrine. Still, a patient he's present and he's catecholamine resistant shock, you can think about patient start patient on and cardiac index is less than for the normal. Is usually the target usually 3.32 for this patient and to up to 6 for this patient cardiac index. If he is still not approaching or not reach that your target, you can think about ECMO, and that's meaning patient refractory shock, and you have to be manage the patient. Patient he lack of history of fluid loss and history of the heart disease or hepatomegaly, or patient his rails and cardiomegaly and failure to improve that perfusion with adequate oxygenation and ventilation. Heart rate and volume is expansion, suggest of that patient maybe is cardiogenic, or maybe is or the extremity shock component. You have to start think about inotrope as vasopressor. Consider appropriate inotrope and vasopressor support for this patient. You have to be familiar how that important inotropes is working. Dopamine. If he's we are working with the dopamine, he's working the beta 1 and beta 2 with the low dose. With high dose, he's working in the alpha, so will be make vasoconstriction, and that will be adequate for the increase the systemic vascular resistance. If you want that's working in the low dose, in the beta 1 and beta 2 will be increase the cardiac output, and is good for low cardiac output state. So the dopamine is just only working the beta 1 and beta 2, just is increase the cardiac output, is good for cardiac contractility, poor cardiac contractility. Epinephrine, if he is low dose, he will work in the beta 1 and beta 2, will be increase the cardiac output. It's good for cold shock, but if he's in high dose, will be working the alpha. If he's giving this 0.3 microgram per kg per minute, so will be make vasoconstriction and can increase systemic vascular resistance for this patient. Norepinephrine for this patient is working the alpha. Beta 1, beta 2 is in high dose if patient make vasoconstriction and can affect in the cardiac output. Warm shock can be used for this norepinephrine, and the epinephrine used for cold shock. Hypovolemic shock is one of most common or important and common type of shock. It results in decrease of the circulation blood volume, decrease of preload, and decrease in the stroke volume, and the results in decrease in the cardiac output. Usually the etiology for this one may be due to hemorrhage or renal or GI fluid loss or capillary leak syndrome. Clinically is very important. You have to make good clinical assessment. History of vomiting and diarrhea or trauma or blood loss, like scenario that's presented by Dr. Mohammed Al-Fayfi in the beginning of that patient with the severe trauma, how to approach the patient. One of the examples, this one patient may be losing blood and how to start the patient. If a patient sure in this patient losing blood, you can start cross match and request blood, immediate give blood for this blood products for this patient. So any sign of dehydration, dry mucous membrane, absence of tear, decrease of skin turgor, hypotension, tachycardic without any sign of the congestive heart failure. So it's very common cause of the shock in the United States, the hemorrhagic shock, one of the important cause of the depleted and decrease of the volume and the hypovolemic shock. Patient may be present with the obvious history, clear, like patient is engaged with trauma or patient in the motor vehicle accident. You have to search what is the site of blood loss. If there is any obvious or some organ, concealed organ like liver or spleen or intracranial or GI or long bone fracture. So we have to be think about this one, and you have to be put in your differential. If the patient presents with the hypotension and tachycardia and pillar, this is the common presentation of patient with hemorrhagic shock. What you have to do, always you have to begin with the ABC for this one, airway and breathing and circulation. I have to replace the circulating blood volume rapidly. Start with the crystalloid. You can start with going with the blood product as soon as possible when available for that hemorrhagic shock. It's very important to start the blood immediately and very rapidly, given this patient type, and can go for what's the type blood group and correspond in the first blood draw. Replace the ongoing fluid loss and treat the underlying cause. This one can help you to give rapid fluid or bolus. Just put the stopcock for this one, and they could make good line from that bag, and the other line will be connected to the patient. You can just close to the side of the patient and just pull from the IV bag. Then after that, you can turn off the side of the bag and then open to the side of the patient. You can push to the patient and to rehydrate the patient rapidly. Septic shock is one of the other important differential for the shock. It's very important. It depends on the clinical, what is septic infection or presence of sign of the decrease of perfusion, like tachycardia, decrease of alertness. So there is two important type of shock, septic shock, cold shock and warm shock. Usually the capillary fill will be more than 2 seconds in the cold shock. Warm shock will be flash, capillary fill will be maybe normal for this patient. So it's very important to think about the warm shock if the patient present, if in patient is normal capillary fill. Peripheral pulse may be diminished in the cold shock. Pounding in the warm shock, and mottling of skin present in the cold, and warm shock is absent. What's the risk factor for this? A patient less than 1 month is highly risk. Our patient with the serious injury like major trauma or burn, or patient involved in traffic accident or penetrating wound or burn for this patient. Maybe patient present with the chronic disease for medical condition for this patient, or maybe patient is non-case immunosuppression, or patient with he has a history of large surgical incision, or during vascular catheter. This is increase of the chance of that infection for this patient. So urinary tract abnormality, this other important risk factor, and frequent infection can happen for this patient. It's very important to have this SARS. This SARS is systemic inflammatory response syndrome. sensitivity around 31 and specificity is around 95. SARS include, if you include 2 of more than the following, that's meaning patient he has SARS, that increase the index or suspicion of that sepsis of what this patient. It's very important to depend on the temperature, heart rate, respiratory rate, and white blood cell. So if the patient is heart rate, temperature or rectal temperature is more than 38.5, or patient is hypothermic, is one factor in the SARS. Second important thing is heart rate. You have to be sure the patient is not tachycardic, not deviated above that normal for this patient. And you have to be familiar what's the normal for this age of this patient. And also if the patient increase the heart rate or decrease the heart rate or bradycardia. Also the respiratory rate, you have to be sure what's the good and what's the normal for respiratory rate for this age, if it's high or decrease for this patient. Also, leukocytes, very important to be sure this patient has leukopenia or leukocytosis. If the patient present with sepsis, that's meaning patient is SARS with suspected or confirmed infection for this patient. If the patient is severe sepsis, so this patient with the sepsis with plus organ dysfunction or failure of that organ. Okay. There is different organ can be affected by the patient dysfunction of failure or shock, because in the patient in septic shock, like the cardiac, it's very important. Patient present they are with the hypotension, or patient desatic or hypercarbia for this patient, or neurological patient decrease the level of consciousness. Patient maybe hematological problem like decrease the platelet, renal decrease of urine output, or this patient increase the creatinine and then maybe twofold of the normal for this patient. Hepatic increase the liver enzyme for this patient. So if this disease is continuing for this sepsis, the patient will be with life-threatening infection, often present with the fever and excessive or persistent tachycardia, or tachycardia with tachypnea and sign of the worsening of the perfusion proceed with the hypotension. A patient present with hypotension is late. It's ominous sign for this pediatric patient, so often followed by the cardiopulmonary collapse or maybe arrested. So we have to, what's the important thing? You have to stop the progression of the hypotension or decompensated shock by early aggressive intervention and improve and manage the guide by giving normal temperature, give fluid, give starting drops. All the management started from early and start antibiotic for this patient. Early compensated and hyperdynamic status for this patient. Clinical sign can be present with the warm extremities and pounding pulse or tachycardia or tachypneic or confusion. Physiological parameters like widening pulse pressure, increase the cardiac output and mixed venous saturation, and decrease the systemic vascular resistance. What's the finding for this patient? Usually present with the hypocarbia or elevated lactate or hypoglycemia. So it's very important to be familiar for this one. How's that make good assessment or resuscitation for the patient with the present with the septic shock? If a patient present with the septic shock will be divided into two groups, as a suspected septic shock or confirmed, or patient sepsis, or it's still you are not sure about it, or suspected of shock. If the patient confirmed in patient septic shock, first hour you have to recognize the patient with the septic shock, and you have to start your management, obtain IP or IO access, collect blood culture, start empiric broad spectrum antibiotic, good measurement for lactate, and you can start fluid if the patient is in shock. Start vasoactive agent, or if shock is still persist, even given the fluid is not showing any improvement. If you are doubting or still not confirmed, you have 3 hours and you have to expedite that diagnostic. We have to find what's the good lab result of this one to help you and to guide you if he's to confirm that he's in shock or not. And then start same management for this one if you are confirmed and show this one. That's 5 or 6 measurements for management of the patient. He's in shock. If this patient presents with the healthcare system with intensive care, if patient present with abnormal perfusion with or without hypotension, if there is any sign of the fluid overloaded or absent, or you have to give bolus. Repeat assessment for this patient, okay, for hemodynamic response of the fluid, and consider fluid bolus again until the shock is resolved or sign of fluid overload is developed. Make good assess for the cardiac function. Consider epinephrine if the patient myocardial dysfunction, or epinephrine, norepinephrine if the patient is resist after the 460 ml given for this patient and not showing an improvement in the blood pressure. But if the patient is without intensive care, depend of that abnormal perfusion, without hypotension, don't give fluid bolus unless there is a sign of the dehydration or that's ongoing fluid loss for this patient like diarrhea or whatever. Start maintenance fluid, monitoring the hemodynamically closely, consider vasoactive inotropes support for this patient is available. But if the patient with the hypotension will doing the same what you're giving for the first group for this patient. Cardiogenic shock is different for this patient, like patient present with the dysarrhythmia or infections and myocarditis or metabolic or drug intoxication or congenital heart disease or trauma for this patient. So what the differentiation, how to make good differentiation from the other type of the shock? By history, by examination, like enlarged liver or gallop rhythm. Patient may be present with the murmur. Rails for this one, for auscultate chest X-ray, enlarged heart or pulmonary venous congestion. So management, what have to manage patient with cardiogenic shock? You have to improve the cardiac output by correct dysarrhythmia, optimize preload, improve the contractility, reduce afterload, minimize cardiac work by maintaining normal temperature, sedation, intubation, and mechanical ventilation, and correct the anemia for this patient. Distributive shock due to the abnormality of the vascular tone leading to the peripheral pooling of the blood with the relative hypovolemia. Usually, etiology can be due to the anaphylaxis or drug toxicity or neurological injury or early sepsis. Management, fluid, and treat the underlying cause for this patient. Obstructive shock is different etiology for this one. Can be due to congenital heart disease or massive pulmonary embolism or tension pneumothorax or tamponade. Inadequate cardiac output in this phase of this adequate preload or contractility, treat the underlying cause for this patient. Dissociative shock for this patient can be an ability of that hemoglobin molecule to give up the oxygen to the tissue, but like etiology like carbon monoxide poisoning or methylglobinaemia or patient it's good tissue perfusion and adequate and oxygen release to the tissue is abnormal. That's the main cause for this shock. Early recognition of this patient treatment and cause of the main therapy for this one. This can happen in this our season for this one, especially for the winter season. That's one using that using that work can be exposed for patient for carbon monoxide. Many cases can be presented this winter, so it's very important to be highly index and suspicion for any patient present he's in shock, think about if he's maintained perfusion and this one, think about dissociative shock for this patient. What the clinical characteristic by the type of shock, you have to be think about if he's a patient present with hypothalamic shock, like hemorrhagic or dehydration, will be increase the heart rate, decrease the blood pressure, and decrease the cardiac output. That capillary time will be delay, and cold extremity and systemic vascular resistance will be high. Cardiogenic shock, usually like myocarditis or dysarrhythmia, will be increase the heart rate, decrease the blood pressure and cardiac output, and there is if we delay for the capillary refill, and extremity temperature will be very cold for this patient, systemic vascular resistance will be high. About distributive shock is depend. Sometimes he's warm or cold shock. If he's warm shock, will be increased, that's cardiac output. If he's cold shock, will be decreased. Blood pressure is also decrease and the heart rate increase. Capillary filling time flush with the warm shock or delay. If he's speaking about cold shock, depend the extremities temperature is maybe warm or cold. Systemic vascular resistance also maybe change low for that patient with the warm shock or high with the cold shock. And depend on this patient, you can start your treatment for this patient. Neurogenic, spinal and cord injury, automatic brain injury, decrease the heart rate and the blood pressure decrease, also cardiac output is decreased. A patient capillary filling time will be flush or normal, extremities will be warm, systemic vascular resistance is low. Obstructive shock maybe due to tamponade or tension pneumothorax, increase the heart rate and decrease the blood pressure and cardiac output, and delay capillary failure. Digestive shock, this carbon monoxide will be normal for capillary failure and also the temperature. But also the cardiac output is high, will blood pressure would be normal or increase and heart rate increase for this patient. I mentioned this one in the first lecture for me for rush protocol is one of the important tool or skills you have to utilize in the patient present to the ER to think about patient shock to make good assessment and differentiation between the type of shock for this patient. So rapid ultrasound in shock patient to evaluate if this critically patient ill or not. So we can make good evaluation for the pump for this patient, and you can after that you see if it's cardiogenic or any how's the heart rate, how's the patient depleted the fluid. So it's very important. And then you can go for tank, you can make good assessment for all the area like in the fast. So after that, you can go for good assessment for the pipe and check with the patient his dissection or AAA for this patient or DVT for this patient to make clear guide you for make good assessment for the patient visit with the shock. So in summary, early recognize shock and early direct therapy, it will be decrease the mortality rate. Rapid fluid resuscitation in the first hour is very important. And recognizing the suspected infection etiology early started of the antibiotic. Fluid refractory shock, peripheral IV or IO erythrops infusion is very important. Consider hydrocortisone with the cotocolamine resistant shock, correct electrolyte and glucose problems quickly. If the patient is not responding to the way you think, he should broaden your differential and think about other differential diagnosis for this patient or type of the shock. Okay, thank you. Any question about shock? If you have any question, you can go to the next. Okay. So we can move to the next lecture. I think it's very important to have some skills and some procedure. Okay. So if sometimes you feel some important for you, especially for if you have limited resource, you have some skills wise to manage some cases can present to the ER. So it's very important to familiar some procedure and how to make some management for many patients can be present, and we can be make this procedure without consultation to the other subspecialty for some minor procedure. Usually the minor procedure can be quick to be performed in the emergency department, and minimal risk for this patient, and will be provide great benefit to the patient if he is present to the ER. Let's start. This one patient, he's 2 years old, again, was swinging in the jungle gym. He's in park. He's unable to lift his right arm, or she's cannot able to lift his right arm. There is pain, appear to be localized to the elbow. There is no swelling, no deformity, or focal tenderness. So it's common presentation for this patient and can be presented this one. There is no trauma, no anything. We are sure this patient not trauma. There is no deformity, no swelling for this patient. So just only like bolt, this one. So we think about nurse-made elbow for this patient, and you think due to that bolt, that's elbow for this one. That occurs with this one between age 1 to 5 years old and precipitated by the traction of the arm, like swinging by the wrist and pulling by the arm, or struggling to the cord. So this is interruption of that annular ligament between the radial head, sorry, let me show you. Between the radial head and the capitulum, this will be make this is a restriction and the pain. So this patient, he keep this forearm or will be not flexed, is extend, and he cannot flex this one, and with pain when you move this one. How to manage this patient? It's very important, very simple. Just reassure the parent. Then you can keep your hand when you handling left one. You can just use the same side, and the other one will be support in the elbow. So will be support the elbow, and the other one will be holding the same side of the forearm of the hand. Then you can do two procedures. Both is succeed, but the best one is hyperpronation, as to do supination or hyperpronation for this patient. If you're doing hyperpronation for this one, you can feel, if you fail in the first supination, you can go hyperpronation for this patient, will be succeed, and you can feel some like pop for this one. You can feeling this one. After that, you ask the patient or ask the mother to lead the patient to move the same side if he's make good reduction for this one, and now go back to way normal. Diagnosis study is no need for diagnosis study for this patient, just only clear or classic history for this one, no focal tenderness, bruising or edema to be sure this patient is clearly is boiled elbow. Radiograph for this one for elbow is aquafocal, is no one not add any benefit for this patient. So it's very important to be not to expose the patient for X-ray if you are sure this patient from the history, and improve after make good reduction for this patient. This other patient, he's 15 years old. Boy was trying to get his pants on so fast that he got himself caught in the zipper. So he is obvious discomfort while he's clutching his groin for this one. What you have to do for this patient? He's this is the you know that's zippered and entrapment. So you have to be how to remove or release that tissue is very important. And what's a good procedure for this patient? Provide local anesthesia for this patient, and we have 4 options. As to be used mineral oil, or just to cut the zipper teeth for this one, or to cut the median bar, or lateral compression of the fastener. So all the 4 techniques I will mention this now. Cut the zipper teeth, this one, you can just cut this one using that's by scissor or by the cutter, or you have to cut the teeth above and below the interrupt area to release this tissue. This one is very quicker than that's cutting the median bar. Or you can just, what you have to do, just using the wire cutter or cutter median bar for this patient. This will be, teeth will be released and maybe make some muscles for heavy duty zipper for this one to remove this one after the cut is done by the cutter. Other technique you can utilize bilateral compression for this one for fastener. If you lateral compression for the fastener, this one maybe is good to cut the zipper teeth and both sides of the fasteners using the pliers for this one, compress both sides of the fastener. That will be teeth will be released from the fasteners. So it's maybe as to cut up and down of that zipper for this one, of the trapped tissue, or just to cut the main bar for this one, okay, or to make good pressure for that fastener to release the tissue for this one. After care, local wound care, okay. And if the glands or the meatus for this one involved, consider urology consult for possible urethral injury, and retain if he's unable to urinate. It's very important. It's very quick and it's better for this one. The third case scenario can be presented AR. It's very common to see like this one. This is the 10 years old girl presented with the emergency department with severe pain and swelling of her left ring finger. There was a trapped ring. How can we manage it like this one? This presents of constructed band or finger leading to the pain and ischemia, maybe due to the ring size, or maybe the edema secondary to this ring. What you have to do? First, you have to prepare your equipment for this one, like lubricant. Maybe you can use dry silk size 2, or umbilical tape, and you can find if you have a ring cutter for this one, and you utilize the lidocaine for this patient. Explain the procedure for the patient and for the parent. elevate the hand a little bit to decrease the edema or the swelling. You can apply ice to the finger for 5 minutes. Then you can clean the area with the sterile water for this one. Then after that, what you have to do, if you just working with the string rub, you can place that the first end of the suture under the ring. Okay, first suture you can put the under the ring, and you can rubbing reminder of the remain for that string for this one, or that silk. You can make this one more distally, okay, over the proximal interphalanx. Then you can pull the proximal part end toward the fingertip, and first put the first end underneath of that ring. Then you can just rub that remaining part for this one to the distal finger, covering the proximal interphalanx. Okay. Then after that, you can pull this one. This one will decrease the edema, and you can easy to release the trapped ring. If you find some difficulty and then it failed, you can use the ring cutter tool. You can place the just guard under that thinnest part of that ring to protect the tissue. Then you can utilize that like electrical or manual ring cutter to start to cut the ring. Then you can use the hemostat to remove the both ends from each other to remove the ring from and release that trapped ring. Other technique, you can use the glove. You can use the glove method. Like what? You can just place that part from the gloves. Just cut the gloves finger part, and you can put a portion of this gloves on the patient finger by passing this proximal portion of this part underneath of that ringer and using the forceps or hemostat to be put this finger or gloves part to be underneath of that trapped ring. Then after that, you can just pull the proximal part or edge toward the distal part to find it is easy to release that finger or trapped finger. The case scenario number 4, this patient, 3 years old boy, was trying to kick ball and so fast, but this unfortunately he kicked that large stone. Then he had swelling and pain on the right big toe. It's common to see like this patient. What you have to do? Now you sure this patient sublingual hematoma. You have to make good drainage for this one. Or sometimes it can be due to secondary to foreign body. So what's the indication? This is throbbing pain associated with the blood collection under the nail. Sometimes due to secondary to foreign body is trapped under the nail. What your equipment? This you have to be for hematoma like electrocautery, paper clip, lighter, and hemostat. For foreign body, remove the foreign body just to be have lidocaine, hemostat, and blade scalpel, and small scissors for this patient. So what you have to do for this patient, you have to, for nail trephination, just to use the paper clip, and you have to warm this one paper clip by the lighter, and you can make hole in the nail 3 to 4 millimeter for this one to release the blood. After, make good cleaning for that area And also maybe can make a digital block for this patient. Nail bit would be exploration, not be indicated, not indicate at all. No need to remove the nail and to make good exploration. No, you can just, it's enough for you to make a good termination hole in the nail plate. That's more than enough and release the blood. Sometimes can use the electrical cautery for termination. Sometimes it's not available, so you can use the paper clip and warming this one by lighter. How to remove the foreign body, trapped foreign body? It's very easy. There is two techniques for this one. One technique you can use just to, first, if you have to be make good digital block for this patient, then first, as if you see that foreign body, just to make good shaving for over the foreign body, must like by scalpel, until that foreign body can be grasped and easy to remove. So what you have to do first, make just shaving by the scalpel to be to be reached that point, you can be removed and you can grasp the foreign body. If you're feeling some difficulty for that technique, you can make like wedge shape, okay, to the side of the foreign body. And you can, after that, if there's exposed that foreign body, you can just grasp this one and remove it. After that, of the hematoma, you can make patient in socks, or no need for start patient antibiotic. For removal of foreign body, just cover the exposed nail bit with non-adherent dressing for this patient. If the patient then foreign body in the foot, you can make start patient or using the socks. No benefit to start patient antibiotic for this patient. Keep cautery hot during the hematoma drainage. Blood usually liquid for up to 48 hours. Expose adequate portion of the foreign body to be easy to not to remove it without not feeling difficulty, or the foreign body may be break during that procedure. The case scenario number 5, patient 2 years old girl complaining of the fever. She had pain, swelling, and redness of her left index. What you have to do, indication, you have to relieve the pain for this patient by digital block, and also to release the pressure for the stats bus. Treatment of the infection. So the most very important for to treat the infection for this one. Soft tissue around the nail, baranica, or to in the nail finger bulb like filon. Prevention of the complication can be happen for this patient if you leave this filon or baranica. What's your equipment for this one? Just blade scalpel. You can use the ethyl chloride or ice for to decrease that pain for this patient, and you can use the lidocaine for this patient. What you have to do, if you are procedure for filon, you know that filon, the bulb of that finger, digital block, you can make a good incision or incise vertically over the area of that fluctuant. Don't make incision transfers position. If the filon is more lateral, you can make incised barrel to the or just below the nail. You can use the hemostat to break up that for the, if there is any ejaculation for this one. You can insert backing if you need or indicated, and you can make good splint and clean the area. For proximal paronychia, just local or topical anesthesia. Lift the nail fold with the blade to release the pus. No need to make an incision. Lateral paronychia just only insist over the area of that fluctuant. Some are recommended to remove the lateral surface of that nail. You can use part of the nail to release that pus if indicated. After doing this procedure, you can just, if he's speaking about the foot, you can use the socks. Topical or systemic antibiotic may be indicated for unproven benefit, but is uniformly recommended for felon. Consider anti-staph and oral anaerobe coverage for this patient. The case scenario number 6, he's 15 years old boy complaining of fever in the last 2 days. He had severe pain, swelling and redness of the left big toe since that last week. No history of trauma. What you have to do for this patient? This ingrown nail have to move for repairing. First indication for this one, you have to relieve the pain. Treatment of the infection associated with the hyperplasia of that nail groove epithelium. What equipment need for this one? Lidocaine, hemostat, and scissor, nail splitter, and silver nitrate maybe need for this patient. We have to do this one. We have to make the good digital block for this patient. If this is ingrown nail is just only minor, you can just only elevate it lateral corner of the nail with the hemostat and place the piece of that petroleum jelly gauze under the nail. No need more than this. If this moderate, remove the triangular section from that distal aspect of that lateral nail edge. You can make good dress with the antibacterial ointment and gauze. For moderate to severe, you can make good cut nail longitudinal down to the aponychia to be make clear cut for this part of the nail bed with a scissor or nail splitter. Grasp the length of this incised nail with the straight hemostat and pull gently to remove it and gently to clean the nail bed and to be remove that and make good debridement to that the tissue or this is infected tissue. After that, you can consider anti-staph antibiotic. If this is virulent present, socks for the patient, for socks foot several times per day for a week or more. You can make a good trim nail transversely, and you can wear loose fitting footwear. This patient, case number 7, or case number 7. This patient is 12 years old girl complaining of the stuck right earring. She had pain and redness with swelling in the right ear lobe. What you have to do for this patient? You know, this some cases can be present to the ER with the stuck earring. And you have to remove it, and treatment of the infection or pain can with this patient. What the equipment needs? You have to bring, blade scalpel, lidocaine, povidone or iodine, forceps and hemostates. What's the procedure? The simple, and you can see that back for this one, like sometimes the most airing back have like metal strips for this one, pinning into ring shape. That will be hold the stud in place. So most airing back have the metal strips for this one that's pinned into the rings that we hold the stud in place. So that's the stud in place. How to release this one? Just by cleaning the surface of the air loop with the aseptic technique, then local infiltration of lidocaine. Then what you have to do for this one, just apply pressure on the anterior portion of the air loop by the finger of non-dominant hand. The other one will be, once this airing back exposed, that stud can be removed by spreading of that ring from each other by the forceps to remove that the stud from that back strip of rings for this one, and it can be easy to release and remove it. But the other problem, if you cannot visualize, okay, so what you have to do, by a small forceps or bit of the hemostat, you have to clamp is then insert into the rear opening and gently opened in order to grasp this airing back. Make good clean the area and irrigation for this one, then filtrate by lidocaine for this one. You can sometimes make good incision, may be needed to be exposed and for removal of the airing. If you just try to expose that back one and try to release this one and expose this one and release by like what you spreading of that strap, this one or bent of that loops from each other, and release this one, and you can be released that stud from the patient or from the air. What the complication can happen for this one is poor skin or cartilage alignment. Infection can be happen with this patient with the possible this pericarditis, cartilage destruction, maybe disfigure or disfigurement of that external ear, and if don't clean or irrigate wound, you have to clean and irrigate the wound and avoid this debridement of the cartilage to avoid that complication can happen for this patient. Avoid placing suture into the cartilage to avoid any deformity or can happen, any complication can happen for the cartilage or in the air loop. The last case scenario for this patient is 2 years boy complaining of foreign body. Is the left nostril with nasal discharge. What you have to do for this patient? What's the indication for this virus? Basically, the child has repeatedly placed the foreign body in the nose, basis of nasal discharge, or patient recurrent epistaxis for patient, or patient present with a halitosis for this patient. So what's the equipment you have to be available for you? The lighting and nasal speculum, lidocaine, ambu bag, suction, yanker, and alligator forceps and right angle curate. What you have to do for this patient? First, to try release the foreign body by non-invasive positive pressure removal by patient kiss. You have to ask the parent to be occlude or blocked the non-affected nostril with the finger. The parents, you have to be administers forceful mouth-to-mouth breathe. Sometimes it's very helpful, or maybe can work with this one and can release this foreign body. If not, you can use by the physician, can be performed that by bagging for this one, and also same close or occluded for the non-affected side of nostril, and try to be very gently to avoid any complication can happen by power trauma, or like any complication can happen for this patient. Sometimes difficult to remove by this technique, so we have to go for this procedure. What you have to do, perform sedation if necessary, if the patient is struggling with you, insert a nasal speculum and visualize the object to determine its size and the location and the orientation. Then you can remove the foreign body. How can it's hard or smooth foreign body? Insert the removal instrument just parallel to the nasal turbinate straight in, and until the tip is behind the object, then pull outwards. Otherwise, you can make, if it's very soft, by grasping this one with the forceps and remove it. Re-inspect, very important to be sure there is no other foreign body in the nasal cavity after remove the foreign body. Success depends on what the size of the foreign body, location of the foreign body, and the duration of the time. And also this very adequately is immobilize the child during this procedure, very important for this patient. You can utilize this textbooks, very good textbook for this is for as a reference for many procedure can do in the ER, and you could utilize this procedure. Any question? Some
نبدأ. أولا نبدأ بسم الله الرحمن الرحيم، ثم نصلي ونسلم على أشرف الأنبياء والمرسلين سيدنا وحبيبنا عليه أفضل الصلاة والتسليم محمد بن عبد الله. إن شاء الله this lecture إن شاء الله it will be light effective to present about the common toxicology in pediatrics, and that's commonly be mistake there. This is actually one of the recommended textbook. This is a huge textbook, actually, more than 1,000 paper about Goldfrank's toxicology emergency. You need to have it, either a PDF or hard copy in the emergency area. This is highly recommended. Also, this is my preferred book. This actually the book always with in my bag. Actually, it's not cover everything, but it's simple, straightforward, covering the commonest tox in emergency. Even it's including the how to treat a scorpion and the snake bites in emergency. It's actually is a big help. Actually, it's not cover everything, but it's cover the most common toxic in emergency. If you want more details, this textbook. Let's cover most of the tox in the emergency. Well, let me take it to cases, discuss other cases. This is a 3 years old child. His parents run an emergency department because of the child start to have generalized seizures at home, tonic-clonic. Seizure will last for around 5 minutes or less than 5 minutes. There is no history of fever or current illness. Past medical history is negative. No family history of seizures. He's the only one child having this stress attack. It's panic for everyone. There is no fever. When he came to the emergency, vital signs showing here, temperature 39, he was tachycardic 140, respiratory rate is okay, 20, blood pressure is high, hypertensive, 140 over 95. Child looks irritable, crying. When you look to the pupils, it's a little bit dilated. We don't know the measurement. Tympanic is clear. Pharynx, there is secretions, it looks moist. Neck is floppy. Chest, it's clear line, no murmurs and regular pulse. And abdominal was hyperactive, bowel sound, and no masses. So in your mind, what is the commonest diagnosis here, or you're really concerned about this patient? What is the commonest diagnosis here? يعني febrile, 4 years, hypoactive, floppy child. Always any child with small child. We need to write also always serious infection also. Even we are in lecture of organophosphate or lecture of toxicology here. But let's go from the toxicology point here. Physical exams having full range of movement. Neurologically, there is no focalities, diaphoretic, hot skin. We don't know now what's going on inside the brain of this child. Is it infected? Is it something, lesions there inside it? Is something from outside? We need to sort it out quickly. What happened here? So let us collect the data now. Let's take a paper, I'll write all our information that we have it now. The child having altered mental status, he having seizure, he having dilated pupils, he's hypertensive, he's having hyperthermia, and diaphoresis. So what's toxins here that cause dilated pupils here? Dilated pupils here. So we can have this abbreviations. AA is A from antihistamine because it causes anticholinergic. Second A is from antidepressant, anticholinergic. Third one is same anticholinergic and sympathomimetic. So what's toxins here cause seizures؟ في ممثل اسمه Otis Campbell. الممثل معروف, actors, comedians. I think he died like 1930 something. He was famous actors and comedian one. So remember his name is Otis Campbell. Otis is O from organophosphate, T, TCA, tricyclic, I from INH and insulin. This will cause seizures. S from sympathomimetic, C from camphor, E from amphetamines, M from methylxanthines, P from PCP, which is, this all drugs being used in the Western manufacturers for hallucinated or something. It's not common nowadays because manufacturers are causing some bad neurological disorders. B from benzo, all the benzo. E from ethylene, ethanol, ethylene glycol. L from lead, L lidocaine. So how to distinguish between anticholinergic and sympathomimetic here? Any answer before we go to the answer here? How can we, this is a common, by the way, confusing, especially when you have a lot of work in emergency and we have a lot of brain block to solve the issues. So this is a common thing that how can we different between anticholinergic and sympathomimetic? Apheresis, skin, okay. So let us sort it out, sympathomimetic and anticholinergic. Both of them, they will increase the temperature of the body. Both of them, they will cause tachycardia, like what happened to the patient, and hypertensions. Both of them, they will cause mydriasis, dilated pupils. But sympathomimetic will cause more diaphoresis and active bowel sounds. So our case is going with sympathomimetic or anticholinergic. Okay. So common forms of stimulant here: cocaine, amphetamine, weight loss product, either caffeine or VPA or OTC analeptic like caffeine. It's used also for weight for sport or exercise purposes. Yeah, sympathomimetic will cause diaphoresis. I already mentioned it there. Right. So our investigation here, labs was normal, CSF is normal, CT normal, urine tox screen here was positive for coke. So this is simply what's going on in the cocaine and the addicting peoples, what they are doing here. So how would this reach to the child, cocaine here? It's cocaine mechanism of actions. It's actually, it can be in the toxic screen. You will have, there's a cocaine, one of the items there. It's inhibit the catecholamine reuptake and CNS stimulations. It can be through the smoke. And this is the problems when you smoke, when the parents are smoking at home, the child can inhale it. It can be using also IV product. The many people who's addicted to cocaine, they like it to smoke. Why? Because the fast effect within 1 or 2 minutes. That's why we see the movie, they are grouping of people and they taking cocaines together. Also, there is the other one, it's the nasal absorptions, which is sometimes not preferred to the addictors' parents for the nasal absorption, because take effect within 20 to 30 minutes, take half hour till you get the maximum effect of it. هذه common بيمسكونهم في الجمارك كثير. What do you call it this one? دائما لما يسوون اكس راي في الجمارك في الكوستمز here, they found this picture. What is it? Is it constipation? I'm sure everyone know about it. Is this constipation or something? This, when you think about someone, usually they will take a X-ray, and what's going on there? What do you call it? No, they call it body buckers. Actually, they do it packing of the drugs or cokes inside the plastic, and they will firmly close it, or sometimes they will take the condoms and they will put it in small groups here and they will swallow it عشان بس يعدي البورد, يعدي الحدود, then they will take it back again and they will sell it to the others. Sometimes this one or two will be ruptured inside the stomach, and this is lethal, immediately death. الكوكايين ايش بيسوي وليش الناس بيحبونه اعوذ بالله؟ It's initially making euphoria ويحس نفسه مبسوط. Then after that you will have an anxiety because sympathometric, agitation, psychosis, muscle rigidity, hyperactivities. Sometimes you have diarrhea. You will start to have the side effect, hypertensions, chest pain because of the fast heart rate. Seizures are usually brief and self-limit. The effect of that one may be having some, because of the inhaled cocaine, maybe having pneumothorax, pneumomediastinums. This picture, as we mentioned, is called the body buckers. هذا المهربين معروف عنهم بالإكس راي هذه. أنا شوي سلو الباوربوينت عشان كذا السلايد عندي. تلقى الام بتاخذ لا قدر الله الكوكايين حيروح للبلاسنتا، يعني هي باسك البلاسنتا الكوكاين، او لما الام تكون بريست فيدرز ذا تشايلد to go from the mother cocaine حيروح على طريق البلاسنتا contaminations، او ال commonest methods for the kids who having الكوكايين عن طريق الباسيف exposures، بيدخنون او بينتشر في الهواء، يعني الرذاذ حقه child he will inhale it at homes. احيانا في group people who smoke cocaine with they put one machine and they would زي اللي تبخ ويكون kids معهم فيها. برضه another medication هي الامفيتامينز، ميثامفيتامين، الاس تي بي اللي هي سيرينيتين، الترانكولينز، الام دي اي and MDMA. This case the child has been exposed to the one of the parents cocaine. حنشوفها أكثر في ال Western countries and few we are seeing case here but very few here. طيب case number 2 بسم الله. This is a 6-year-old boy brought to the emergency by the ambulance for respiratory distress. His parents state that he awoke that morning and went outside to play, returning in distress. الولد كان كويس، راح الجاردنز، رجع الرجال مكتوم، distress, fast breathing. We don't know what's happened in the short period, 1 hour. He has no significant past medical history and takes no medications. In this case, we should also think about toxicology, and also some of the kids who are having metabolic disorder, they may present with hypoglycemia. So always think widely, not only think always in one differential diagnosis. We may have so many differential diagnoses. XPD, one of the glucose phosphates that's having abnormality with the glycogen disorders, when they play 2 hours in the gardens, they will have sharp hypoglycemia. We need to be careful about like shit like this diagnosis. طيب هنتكلم في التوكسيكولوجي احنا الحين. This temperature was normal, heart rate 140, respiratory rate 70, blood pressures 95/70. أنا في حاجة هنا I miss it significant. في الترياج والاسسمنت بلانج ايش هي؟ في حاجه انا هنا نسيت اسويها. I forget to do it here. What is it? Something very important. I miss it here. I just mentioned it before. Glucose, yes, it's a 6 fatal signs. 5th is saturation and 6 is vital sign. There's oxygens. Here I forget to make a blood sugar here, which may be severely hypoglycemic. Child is lethargic and obvious respiratory distress with retractions. Pupils here, is it normal 2 millimeters or not? And saturation, yes. Okay, good. So 2 millimeters only, the pupils. بس لاحظنا في child having secretions, a lot of oral secretions coming. Is having wheezy also, and there's crepitations and rolls, and all the lungs will be auscultated. Heart is okay. There is heart issue here, no murmurs. The bowel looks active bowel sounds, and there is diarrhea. The child looks diaphoretics. There is non-focal neuro exams and with lethargy. So let us think about toxidromes here. Let us bring paper and let us collect our data that we collected from the patient. Child having 2 millimeters pupils, which is pinpoint pupils. He having lacrimations. He having salivation. So actually he's throwing fluid from everywhere. Diarrhea, he having urinary incontinence. What is this type of toxicodrome? Child having pinpoint pupils, have lacrimations, have salivations, having diarrhea, but the urine close. He's having urinary incontinence. Okay. Let us go more widely now before we jump into the organophosphate. How we pick up the organophosphate. This looks what we call it cholinergic toxidrome. Cholinergic toxidromes. Sludge, dumble. Sludge, dumble. So sludge is from salivation, L, lacrimation, U, urinary incontinence, D, diarrhea and diaphoresis, G, GI abscess and maybe vomiting, E, emesis, D from diaphoresis and diarrhea, U from urinations, M, meiosis, B, bradycardia, E, excess of everything, L, lacrimations, S, salivation. Okay. So in this case, I mean, more approach to through the organophosphate. It's industry, farms, and home as a pesticide, وفيه different power of organophosphate inside the home. Rapid absorption through the skin, inhale, and digested. That's why when the child came to your area, you need to having a decontaminated area. You need to quickly remove the clothes and wash the child because still you will have to continue to absorb from the skin. Available for home use in rock, spray, flare for it. Exposures in the children are cutaneously secondary to contact with the contaminated bedding and clothing. هذا الاهل لما يحطون الاورجانوفوسفات عشان يحاربوا البكس والاشياء هذه في الملابس وزي كذا، فتنحط في الشراشف. فالطفل لما يجي يتغطى خصوصا مع البرد او يتغطى مع المكيف وكذا، يبدا الجلد يصير له absorptions الشيء هذا. وبيجيك pictures في الامرجنسي of organophosphate, but the family, they will deny it totally. There is nothing at home, but you don't know that, and maybe the parents also don't know the source of organophosphate from the bed sheet. Okay, so what's the problems with organophosphate here? From the sulfa acetylcholinesterase inactives here, promote the accumulation of acetylcholine as a muscarinic nicotines and CNS receptors. So this will inhibit the neurons here and paralyze it. You will have the muscarinic effect here, vomiting, diarrhea, abdominal pain, meiosis, bronchospasm, bradycardia, excessive salivation and sweating. You have excess secretion from everywhere, except the urine will be closed. Slud, salivation, lacrimation, urinary, and defecations. They have some also nicotinic effect, muscle fasciculations, tremors, and weakness. Death usually here because of the paralysis of the muscle paralysis because of the effect of acetylcholinesterase receptors blocked, and the child is unable to breathe because the muscle is not working. Okay, CNS here, the effective because of agitation, seizures, and coma. So diagnosis here based on exposure to history and symptoms complex. Many patients here will have solvent or garlic odor. ريحة معروفة يعني ما حد يلخبط فيها. Lab analysis, which is not available everywhere, about the RBC cholinesterase is the most accurate diagnose organophosphate. Plasma cholinesterase activity may be performed, but maybe this is not available everywhere. Treatment here, airway, breathing, circulation, as we know, and E is important also, A, B, C, D, E. E is meaning exposures and remove everything and clean the patient from the from organophosphate in the skin to avoid the absorption, continuous absorption. You're treating it, but still the toxin is coming inside the body. العلاج الآن احنا نعطي atropine 0.05 milligrams per kg, or to give me the maximum adult dose, which is 0.5 to 2 milligrams total dose. It's a maximum dose. This will relieve the muscarinic effect, and you will give it until the lung be dry. So indicate for bronchoria and critical wheezy until the lung be dry from that secretions. Pyridoxine here, الدوز من 20 إلى 50, 20 to 50 milligrams per kg, and maximum عندنا 1 to 2 gram. هذا بيساعد for cleavage of the phosphate bonds and stop blocking the nerves. Most effective in early treatment in the first 24 hours. Week after that, a response is a magic response after half an hour. It will reverse the muscle weakness and fasciculations, and يعني نقول بإذن الله it will avoid the intubation of the patient, to prevent the intubations. I'm using advanced airway. Case number 3. Any question? Okay. Case number 3. This is a 14-year-old boy. He's been brought by ambulance in very busy day. After found walking aimless here. Amos here describe him as drunk. He looks like drunk. He doesn't know where is he going up. There is no history available. Only the child, and child cannot respond to your history. In the exams, 14 years old boy, he's 37, temperature was okay, 37. Respiratory rate a little bit up, 36, heart rate 92, but saturation is 98. He's responding to the pain and he's following the command and conversations. He said that he drank something, doesn't know what is it. Chest abdominal is normal, neurologically looks drunk, but other exam as are remarkable. Can we bring paper and collect our toxidrome here? Labs being requested, 120, ECG normal, lab, CBC, chemistry, ethanol, urine tox, still waiting for the result, and brain CT because this acute change neurologically in the patient. We don't know what's going on with him, so we request brain CT. CBC normal, bicarb, oh my God, 6 only. anion gap 36, urea 8, creatinine 1.3, serum ethanol negative, and CT is unremarkable. So the problem list here is just something, we don't know what is it. Child looks drunk. We don't know why. Is it trauma? Is it? But he said, I'm drinking something. When we do the lab work, we have elevated anion gap, which is important for emergency to know how to calculate the anion gap by ourselves. And ethanol for alcohol is negative. So let's go back. Which one is having high anion gap? We have here high anion gap, which is 36. Which is causing high anion gap? This is the abbreviations, MUD pills. MUD pills. What is MUD pills? M from methanol, U from uremia, D from DKA, P from phenethylamines, I irons, L lactate, E ethanols, also ethylene glycol, S salicylate or salicylic acids. Those causing of high anion gap. But in our emergency, we can rule out many things because we already did ethanol is nothing. Lactate, we have the result from blood gas, normal. Salicylate with toxic screen, nothing. Ethanols, iron, INH, not there because he drank something. He denied any pills. Phenethylamine is not the case here. Uremia is okay with him. DK, his blood sugar is okay. So what we remain by what now? Which one? We will mask it all, and we were remaining by methanol. It's different than ethanols, and ethylene glycol. The point here, how can we calculate the osmolar gaps? It's very important here. Osmolar gap is different between serum in the lab and our calculation of osmolarity. Should be less than 15. Serum osmolarity here is measured by freezing point, the pressing in the lab. لكن here, what we need to do, in our calculation here, to make a double sodium plus urea divided by 2.8 plus glucose divided by 18. إذا أنت بتتعامل working with millimole, no need to divide by 18. It's already there. If you're working with the with DL, no, you need to divide it by 18. For double sodium plus urea divided by 2.8 plus glucose divided by 18 if you're working with the DL. If you're working with millimole, no need to divide it by 18. So agents associated with elevated osmolar gaps here like methanol, ethanol, ethylene glycol اللي هو antifreeze اللي هو motoridator, asbopryl alcohol, mannitol, glycerol, formaldehyde. So his serum osmolarity was high, 36, 360, so around like 60 or 80 gap, more than 15. It's markedly elevated for ethylene glycol levels. Methanol here is negative. He received flumazoles and was treated conservatively as an inpatient, and there is no insult happened. Why we are worrying about ethylene glycols here? Because ethylene glycol, it will be converted by alcohol dehydrogenases to glycoaldehyde, and then we have another enzymes called aldehyde dehydrogenases. It will convert it to glycolide acids, glycolate. Then it will convert to glycosalic acid. حتى نصل للأوكساليك acid والكالسيوم oxalate. هنا المشكلة. Calcium oxalate will be participate in the kidney and they will damage it. So الفomeprazole اللي بنستخدمه antidotes, it will prevent the alcohol dehydrogenases from converting ethylene glycol to glycolaldehyde and then to go to the calcium oxalate. And this is the problems with ethylene glycols. It will destroy the lung. Another one here, another case, it's a mom found ferrous with open bottle hand of her child. Should take the child to the emergency or no? الأم لقيت ولدها ومعاه حبة حبوب مفتوحة of iron. Shall the mother go or call the emergency? Shall I go to the emergency or no? Yes or no? Yes or no? One of the dangerous irons. That's you will not have the symptoms now. It will You'll have it later on. Yes, you need to go. How much the toxic dose of iron? Usually are using calculating the element, not the total dose. So the toxic dose from 40 to 60 milligrams per kg element iron. So you'll take the bottles and try to calculate how many doses of element irons. والعياذ بالله, lethal dose, it's 180 milligrams per kg. We need to remember this numbers here. Yes, 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 yes. ما حد قال no? كله yes? Good. What about this one common multivitamins in home and for the pharmacy? Shall we worry about it or not? Syndromes. Okay, you need also to calculate the good things with this one. Yes, it's 150 of total ferrous fumarate, بس element في كل حبة حتجيك 18 ملغ element iron. فالشايلد إذا كان وزنه 10 كيلو حتكون الليثال دوز حقته 10 حبات. If you take 10 tablets, his weight is 10 kg, that's meaning he's already ingested 180 لا يمكن حتى أكثر to have the toxic dose here. تحتاج حتى 100 حبة 18 إذا أخذ total 180 milligrams of element irons فالتوكسيك دوز حقتها هذه very very low. بس we need to calculate it to double check لأنه فيها حوالي 250 حبة هذه. طب what about the mothers perinatal vitamins? What do you think about it? He ingests like 10 tablets and his weight is 10 kg. element dose element iron اللي موجودة فيها 65 ملغ. فهذا very high dose element. Which organ not affected by iron toxicity? احنا we know انه الايرون بيدخل في الاستومك, بيدخل في البنكرياس, بيدخل في الليفر, و sometimes يعني other, but if there is any organ will not be affected by iron? في organ will not be affected. الليفر ما راح له الايرون, ممتاز. غير الليفر CNS it will be safe from iron, okay. So I'm talking about organ will not be affected. Brain, okay. Any organ will not be affected by iron. طب معلش أنا بخالفكم في الموضوع هذا. الايرون يدخل في كل مكان. None. No single organ will be safe from iron. Iron will attack every organ in the body. Retina, pancreas, brain, bone, retina, lung, cardiac, everything. Iron will participate in everything. So the physiology here for GI tract, it will make erosions, necrosis, bleeding, perforations, loss of the absorption regulations. In the livers will make peripheral necrosis, coagulation defect, hypoglycemia, hyperammonemia. Actually, one of the worst medications for the child if they get it, and it's causing slow death, unfortunately. And many of the time, the level screening treatment will start late. That will be bad prognosis. Cardiovascular system here, myocardial infiltrations, capillary disruptions, vasodilations, hypotension. Also, the coronary will be affected. What's the face? How many face we have of iron presentation here? How many face? How many face you know? We have 4 faces, yes. 4, not 3, 4, please. Phase 1 started from 30 minutes to 6 hours post ingestions. He will start by the commonest GI symptoms, vomiting, diarrhea, abdominal pain, and sometimes this will be confusing us with gastroenteritis, metabolic acidosis, shock, coma, and severe overdose. Phase 2 will start after 6 hours to 1 day post ingestions. Quiescence periods, وضع هادي حيكون. الsymptoms it will be improved. وهنا المشكلة الليفر not yet hurt. Phase 3 to start after 2 days, from half day to 2 days. Post ingestion, having multi-system failures, GI hemorrhage, cardiovascular collapse, metabolic very bad acidosis, pulmonary deteriorations. Phase 4, which is happened after 4 to 6 weeks with a permanent damage, post-ingestion, which is maybe causing gastric outlet obstruction, permanent liver damage, cardiac damage, renal damage, whatever. But the most commonest, it will be making gastric outlet obstruction and or perforation sometimes. See here how it's making the obstruction here. The management of iron. Iron ingestions usually will not responsible to the charcoal. That's why we're not using charcoal always with the iron ingestion. But it's one of the medications that we are using whole bowel irrigations. Bowel irrigations, we are using BIC or polyethylene glycol, which is already fluid made. We'll insert NG to the child, make sure in the gastric area, proper positions, and start the child ½ liter per hour until you see this fluid, polyethylene glycol, in the stool. It's coming outside until you clear the stool. So when he defecates, he will defecate the fluid here, which is the polyethylene glycol. Usually it takes sometimes up to 6 hours to get this issue. The child you will pass the stool until he clear the bowel, and you need to clear the whole bowel with polyethylene glycol. The dose is ½ liter per hour for kids, or 1 to 2 liters for adult or adolescents. You will give polyethylene glycol until he passes it out from the bowel. This is the whole bowel irrigation. ايش في كمان برضو الايرون مانجمنت، نعطي الانتيدوت، نعطي ديفراكسين نعطيه حتى يكلير ذا يوريت، باين فري الايرونز، فلوكسامين، حتى اول شيء حنبدا في الفاين روز هذا انت تبي كونفيرت تو بي كلير يورين. طبعا عيب الديفراكسمين انه بنعطيه في الاي سي يو او في الوردز. You need to check frequently the vital signs، لأنه ممكن يصير عندهم hypotensive anytime. طيب, all alter level of consciousness here patient need to have assessment of anion gaps. Plus طبعا لما اتكلم عن النيورولوجي، عن التروما، عن الانفكشنز، بس هذه as a part of the toxic issues. All toxic alcohol present with any preparations and drunk appearance. Serum osmolarity measurement are reliable and very helpful in emergency. Keep it in your mind, write it in your notes, write it in your mobiles. Don't forget the calculations of osmolarity. Increasing osmolar gaps and acetones, ketones in the urine. It could be isopropyl alcohol. هذا معروف، موجود في الويستن، اللي راح الويستن بشوف كثير، اللي هو الماوث واش اللي محتوي على الكحول. Some of the kids they drink it because having some sweet. فهذا الماوث واش اللي بيحتوي على الكحول، فاحيانا ينحط في الجيرلز او البويز ويشربوا منه. فهذا يسمونه اسبرايل الكحولز، وهذا بيزود الانكريس مولاريتي واسيتونز وكيتونز سويها في اليورين. الاسيدوسز and optic disc hyperemia, think about methanol او يسمونه الكحول المغشوش. Any depressed adolescents with wide complex rhythm, check the bicarb immediately. Fever, agitation, hypertension and seizures, think about cocaine or sympathometric. Or sympathometric because it will accelerate everything. Agitation, sympathometric, nystagmus, PCP, which is manufacturers medications making hallucination. ما اعتقد انها موجوده في الشرق الاوسط هذه، لكن ما احد يعرف ايش ممكن يصير بعدين، انه يعني تهريب ولا شيء. ف keep in mind. Antidote for beta blockers, immediately give glucagon. Shock, acidosis, vomiting, think about iron poisoning. Thank you so much everyone. Very happy to be with you on this update conference. والله يعني كانت it's a nice experience with you and talking to everyone. And I'm happy to receive any question now.